with our younger colleagues. And we will be discussing, every single topic which does, that you're going to come across in your careers. And we've all been through the same route, don't worry. So, it is always good to see what we can add to your conversation and what you can add to our conversation, because I think there's so much happening around. It is difficult to keep pace, but I'm sure the younger lot bring a lot to the table as well. So today we're going to discuss something which I'm sure each one of you would have heard several times, and we want to bring more perspective to it. We want to hear your perspective. And in the process, you will also get mentored by some of the top minds in the oncology framework. So today's topic is early. I request all those who are on to mute themselves so that you can hear what the other person is saying. So please mute yourself if you're not, if you're not active. Yes. So today we're going to be discussing early triple negative breast cancer. So the moment we say triple negative breast cancer, everybody sits up and wants to know more about it. So this is going to be just early triple negative breast cancer. So we're not going to be touching advanced triple negative breast cancer. And why is it that there is such a hullabaloo around triple negative breast cancer? So I will, at this point, invite the mentors who are going to be there for this meeting. So Dr. S.V.S. Deo, you all know, he's the head of surgical oncology at IRCH, AIMS. Everybody knows him. He's a great mind in oncology, and I'm sure we're all extremely delighted to have him open proceedings. The other mentor is Dr. Smriti Hari. She's also a big name in radiology. Her passion is breast radiology, and you will hear what is it that you can pick up on triple negatives on imaging. Then we have Dr. Jyoti Vadhva, my friend and colleague and classmate from college. She's a reputed medical oncologist at Medanta Hospital. Then we have Dr. Kanika Sood, who's a radiation oncologist, a very well-known radiation oncologist in Dharamshila Cancer Hospital. Then we have Dr. Rajat Saha, who is a medical oncologist with Max Hospital. And I'm missing out somebody, am I? Yeah, so Dr. Ashutosh is not there. So I will try and fill in for Dr. Ashutosh Mishra. But right away, I will hand over proceedings to Dr. S.V.S. Deo. So what is different about triple negative?
Yes. Hi, Geeta. Good evening.
Good evening, sir.
Yeah. At the outset, I would like to congratulate Dr. Geeta and the entire team of Delhi Breast Oncology Group for starting this initiative for student education and training. I think a few months back, we have decided we have to bring on the young oncologists of Delhi, such a dynamic workforce which is working all along with the faculty and contributing significantly for the oncology workforce in Delhi. We thought we need to give them a platform to improve the academic interactions and get a perspective of the younger generation. So as part of that, we have started this series, and this is a focused discussion on TNBC. So why we have chosen TNBC, as Geeta has said, it is a very unique sort of breast cancer. I think till 10 years back, we were treating all breast cancers as the same variety using TNM staging. But so much has changed in the last 10 years. Now we have a lot of insights and in-depth understanding of the breast cancer biology. And most of the treatments, I think the breast cancer is the leading way in the era of precision medicine and personalized medicine. So TNBC is a unique challenge. Wherever you see, I think it stands out separately compared to the luminal cancers and HER cancers. Whether you take the presentation, the radiology findings, the pathology, the molecular makeup, the treatment approach, everything is slightly different when it comes to TNBC. There are a lot of controversies, there are a lot of unresolved issues. So today we are going to have a focused discussion for almost 1.5 to 2 hours, mostly involving the students, and a fantastic panel. I would like to invite, I think, Jyoti Vadhva, Kanika Sood, Dr. Rajat Saha. I think a lot of good mentors are there here. So without wasting time, Dr. Smriti Hari, I would like to welcome you, Dr. Smriti. So we will get different perspectives, a lot of participation by the students, and we'll interact, and I am sure it's going to be a very enriching experience for everyone. Thank you, Dr. Geeta. We can start the session.
So let me just get this. Yeah. Okay. Thank you so much, Dr. Deo, for putting things into perspective, and let us get going. The best thing about this whole program is that it is by the students. And I think, like I said, students bring a different flavor. It gets us thinking also. And I'm sure we're going to hear some excellent perspective coming from them. So we are going to talk about 5 pertinent pointers. Everything has a contribution to the way we look at oncology. So I think, imaging, pathology, these are 2 cornerstones of how oncology really pans out. So we will be talking about 5 pertinent pointers in various things like radiology. We talk about a lot about genetics. The moment you say triple negative, you're talking about genetics also. So let's set the ball rolling on those pertinent pointers in radiology with Dr. Srinivas, who's a resident in All India Institute of Medical Sciences in the Department of Radiology. So Dr. Srinivas, if you're ready to share your slides, please go ahead.
Yes, ma'am. I'll share the screen, ma'am. Is my screen visible?
Yes, we can see it clearly.
Good evening. My name is Dr. Srinivas. I am a resident in radiology at TNBC, New Delhi. So I'll be speaking about radiological aspects of triple negative breast cancer. So I'll describe the findings by taking the example of a case. So this case is a 28-year-old lady who complained of a painless progressive lump in the left breast since 2 months. Here, we can see that in the left breast, there is a round equal density mass with circumference margins. In the upper central breast, there is no internal microcalcifications. There is no architectural distortion. Also, we can see a suspicious left axillary node. A few important points to remember here are that it's a round shape, a mass with a round shape and predominant circumscribed margins. And also there are no internal microcalcifications or or the surrounding architectural distortion. Also, it's an enlarged axillary node. Coming to the corresponding ultrasound findings, the mass, it's a round, very hypoechoic mass with circumscribed margins and also with some microlobulations. It shows internal vascularity and also posterior acoustic enhancement. Also, we can see a suspicious left axillary node with raised cortical thickness. Coming to the MRI features, it's a different case. It's a 42-year-old female who complained of a lump in the right breast. Here we can see that it's a round shaped mass with irregular margins showing internal hyperintensity on T2 and peripheral diffusion restriction. And on post contrast, we see a ring kind of enhancement. And on kinetic curve, we see a type 2 pattern. So TNBC cancers are known to have internal T2 high single intensity. They show irregular or smooth margins and a rim pattern of enhancement. So this might mimic a benign tumor. However, they show either a type 2 or a type 3 curve and also a rim enhancement. Since triple negative breast cancer lacks suspicious imaging features such as irregular shape, speculations, or microcalcifications, which are commonly seen in other subtypes, and also it shares some imaging features of benign tumors. So there are a few clues to differentiate triple negative breast cancer from a benign tumor. Clinically, it presents in a young age with aggressive course, plus benign tumors are lumps which are non-progressive in nature or gradually progressive. So coming to the imaging features, they are usually round in shape and have indistinct or microlobulated margins and may be markedly hypoechoic on ultrasound, and also will have an axillary lymph node as enlarged. Whereas benign tumor will be oval, well circumscribed, and hypoechoic, and they don't have an axillary lymph node that's enlarged. Breast cancer. Since TNBC shares imaging features with benign masses, machine learning radiomics models have been developed to help us to help improve the accuracy of diagnosis of triple negative breast cancer with conventional ultrasound. And also incorporation of AI into dynamic breast MRI improves the accuracy of characterizing the lesion as benign or malignant. Thank you.
Thank you very much, Dr. Srinivas, for such a lucid presentation and bringing about, the new role of AIs in, characterizing triple negative breast cancer. I think that slide where you showed how it can actually mimic a benign thing, and it's not actually benign. So you have to keep your ears and eyes open. And I like Dr. Smriti to make a few comments on her experience with triple negative, which I'm sure is huge.
Yes, thank you, Geeta. Yes, we often get patients who have been diagnosed as fibroadenomas outside and turned out to be TNBC. It's a very common scenario because of the imaging appearance, which is so overlapping with the benign tumors. So the index of suspicion has to be very high for these patients, and the radiologists must look for subtle signs of malignancy in every patient where they think it's benign. So before labeling anything as BIRADS 3 or 2, it is the onus of the radiologist to make sure that all of the margin has been seen to the best capability. And in fact, ultrasound is very useful. Things which look completely circumscribed on mammo, you can see subtle undulations, microlobulations, or indistinct margins on ultrasound, and that should provoke a decision to biopsy rather than follow up. And the other thing is that because of their rapid growth, and they don't produce any desmoplasia. So that is the reason there are no architectural distortion, no speculations. It's rather an expansile lesion, a space occupying lesion, which has pushing margins. So we have to consider these features before labeling anything as benign. Thank you.
Thank you. Thank you, Dr. Smriti. That was a very good summing up of the whole. So now I will call upon the next arm of our investigation, and that is the pathologist, something we really can't do away with. And a triple negative also means a lot to the pathologist, because there are new things coming up, because we do know triple negative is tough because there are no markers. We do not have any targets. So it makes it more complicated. So there is always this quest to look for certain biomarkers for triple negative breast cancers. And that is what makes it very, very exciting for the pathologist also. So at this point, I would like to call upon Dr. Kavita. Dr. Kavita is a consultant pathologist in Max Shalimar Bagh with a very special interest in triple negative breast cancer. That's why I thought we should have her on board to hear what those pointers are for triple negative breast cancers. Dr. Kavita, over to you.
Hi, ma'am. Hello to everyone. So thank you for this opportunity, ma'am. I'll just share my screen. So it's a bit more elaborate than the radiology person has done, but I'll try to concise myself as early as possible. Yes, so as the name depicts, the breast cancers with absence of estrogen receptor, progesterone receptor, and HER2 expression are triple negative breast cancers. So there has been a considerable overlap with the basal-like breast cancers, and they have a popular notion that basal-like breast cancers are triple negative breast cancers, and they are synonymous, but that's not the thing. They are not interchangeable. Basal-like breast cancers are defined by gene expression profiling, and they are a specific subtype of triple negative breast cancer. And approximately 80% of TNBCs belong to...
Kavita, we can't see your slides properly. Can you just put it on full screen and go to the first slide?
But ma'am, you can't see my slides?
They're not moving.
They're not moving, yeah.
And they're currently on the last slide.
Yeah, it's on the last slide, yeah.
But from my side, it's like they are moving. How do I go about it then?
Can you just load it again? Yeah.
Yeah, sure, I'll do that. Now are they visible? Hello?
No,
Not
no,
yet,
Dr.
ma'am.
No.
Ma'am, make it full screen. Stop sharing and reshare it by selecting the full screen window.
And I think we can move on to the next. Meanwhile, I'll just try to look because I don't know what's happening.
It was briefly seen for a second. It was visible in between, then it disappeared.
Yeah, so just try. While you try, I will call upon the next speaker. It's just a matter of, sequence. It is okay. So the other aspect that we all focus on very frequently in triple negative breast cancers, especially because these women are young, have not yet started their families. And there is this constant, need to understand something about fertility preservation. In fact, in our dialogues, always discuss fertility preservation because it is important to the patient. In the situation that she finds herself in, a lot of times she may not discuss it, but we have to offer it to her in any case. So I think we need to focus on fertility preservation measures before chemotherapy kicks in. So to discuss the various fertility options, we have with us Dr. Shubham. Dr. Shubham Biduri is a gynae oncology fellow at Max Hospital, Vaishali and Patparganj. And she's going to take us through what are the fertility options for a young lady who has been recently diagnosed with triple negative breast cancer. Over to you, Shubham.
Thank you so much, ma'am, for the opportunity. I hope my slides are visible.
Make it full screen, please.
Yeah, ma'am. Just a moment, ma'am.
I think you can try pressing the play button on top, Shubham.
Right. I'll do that.
Yeah, great.
Okay. So again, I'll just try to make it concise, but I'll just try to speak a little fast. So I just want to focus at how TNBC, we'll start with how TNBC actually affects the fertility. So as you all know that TNBC usually affect the women of age group of usually 30 to 40. And also there is an increasing trend towards delaying first pregnancy. So this age group is that time when women today are delaying the pregnancy. And also this is the age group where TNBC cases are usually found. So this tendency is concordant with an increasing incidence of breast cancer in women who have not yet completed their family. And that's where the role of fertility preservation comes. And that's where the breast surgeon and the oncologist should include the fertility specialist in decision making. Wait, it's not changing. So how is fertility affected in breast cancer or in TNBC? First is, of course, the age of diagnosis. By the age of 40, as we also know, there's a biological clock in females. So 50% there is reduction in the fecundity rate, and to that of a 30-year-old woman. So there is also an increased risk of miscarriages as the age increases. So that's the usual biological clock of every female. And given that premenopausal breast cancer patients are older than 35 years, so this group usually present with a already naturally reduced baseline infertility. So, and also cancer affects the hormones of the ovary, which are very important hormones such as AMH and inhibin. We'll talk about them in detail in further slides. And also FSH. So all these hormones, they basically make the female go towards the ovarian aging. So cancer basically induces ovarian aging in already reduced fertility in cancer patients. Also, so first was the age, then also the use of gonadotoxic chemotherapy drugs. As we all know, they affect the ovarian tissue. Mainly, they destroy the primordial oocytes, the granulosa cells. They also cause significant vascular injury. So the overall tissue of ovary is affected. And thus, the quality of oocyte is reduced, the number of oocytes are reduced. So the fertility comes down. And of course, the more aggressive tumors such as TNBC, they reduce the ovarian reserve. to a much higher level. There's also a role of EFGR, that is epidermal growth factor in TNBC. So basically an overexpression of this also leads to a poor response. So in breast cancer, then more in TNBC, because there's overexpression of EFGR, it leads to a poorer response as compared to the other types of breast cancer. So when to start fertility preservation, when to counsel the patient to go for fertility preservation, this is very important, that upon the diagnosis, the referral to fertility preservation occurs between the primary surgery and of course the start of the adjuvant chemotherapy. Or if you are offering new adjuvant therapy, then such referral can take before the start of the new adjuvant treatment. There has been no evidence that this longer duration treatment is associated with the worse survival. There have been multiple studies and meta-analysis. So they have given the evidence that it doesn't affect the overall survival if we are giving the fertility preservation duration before the new adjuvant chemotherapy. So there are few prerequisites before the fertility preservation. We have to assess the baseline fertility of each woman's ovary. So we have to see their function. What is the baseline function? This is also important legally. So the two very important tests is by anti-Mullerian hormone. It's an AMH hormone which is produced by the antral follicles in the ovary, and it's an important hormone because it tells directly about the function of the ovary. So serum levels of AMH, they are more stable. They can be checked anytime during the menstrual cycle as compared to the estradiol and FSH, which keep changing during the menstrual cycle. So AMH is a very important marker and very important hormone to check before we start any treatment. So it has been found that a cutoff of more than 1.2 nanogram usually is associated with a good outcome, and there is a higher possibility for getting mature oocytes in the IVF cycle. And this is also important legally because you have to tell the patient about the expected outcome. If it is already very low, then you should counsel the patient in that manner. Then other tests are, of course, the ultrasound. We can check the ovarian volume and also the count of the antral follicles. So basically, these are three tests of checking the ovarian reserve of the patient and checking the baseline function of the ovary, which is very, very important before starting any treatment and giving realistic expectation to the patient. So what are the options in today's time? After we have assessed the ovarian reserve, we have assessed the baseline function. There are basically, we can group the methods into three categories. Techniques that try to reduce the impact of chemotherapy. Sorry. That try to reduce the impact of chemotherapy, basically ovarian suppression. So we try to suppress the ovarian function by giving exogenous hormones so that for some time ovaries become dysfunctional or they stop functioning. And after that chemotherapy is complete, we try to regain their function. Then there are techniques in which we obtain the oocyte or the embryo and we cryopreserve them. So this is the most acceptable method in today's time. And of course, the third type is technique in which we try to preserve the ovarian tissue. We freeze the ovarian tissue. That is, and now how relevant each of these is for which patient we are going to discuss in the further slides. So what is ovarian suppression? We basically give exogenous hormone, GnRH agonist. So we give the agonist and we suppress the function of the ovary. So basically American Society of Clinical Oncology have given a various statement that it is not a very effective method of fertility preservation and it is not used as a sole method. However, it can be used to reduce the incidence of amenorrhea in relatively older patients. Basically, we give it to suppress the ovary, and when we stop giving these hormones, the ovarian function comes back. So basically, it has been found that its results are not very good for the fertility preservation, but yes, it reduces the incidence of amenorrhea. It protects the ovarian function in reducing the amenorrhea, but when fertility and the results of fertility preservation are compared, it is not a very good method. Also, it has various disadvantages, like it reduces the effect of chemotherapy, and also it has various hypoestrogenic, because it suppresses the estrogen and progesterone completely. So patient might have some hypoestrogenic symptoms and side effects such as bone loss. Then the most acceptable method is the oocyte and the embryo cryopreservation. What we do is that we stimulate the ovary of the patient by giving ovarian induction drugs. And we look for the number of oocytes produced by basically AMH levels and ultrasound and the antral follicle count. And we retrieve those oocytes and cryopreserve them. Second method is embryo cryopreservation. Embryo cryopreservation is usually preferred in the patient who are married, who have a male donor. So we perform an IVF. We perform an intracytoplasmic sperm injection, and we preserve the embryo at the 8 cell stage and keep it in cryopreservation that can be later implanted into the patient. after the chemotherapy is complete. So basically, in case of embryo cryopreservation, IVF prior to freezing is required. So basically, oocyte preservation is important in patients who are unmarried or who do not have a male donor at that time. And embryo can be done in patients who have a male donor at the time of the start of the treatment. It has been found that oocyte preservation is slightly problematic as compared to embryo, because embryo is more stable and it can withstand the cryopreservation environment. Basically, oocytes are sensitive to chilling, and because of the spindle apparatus and the high lipid content and cooling and cryoprotecting effects, they increase the chances of aneuploidy. Also, the cancer patients are already at a high risk of aneuploidy. So somewhere, if we compare the oocyte and the embryo cryopreservation, of course, embryo cryopreservation has a better outcome. But then it also depends on the condition of the patient and the presence of the male partner. So embryo cryopreservation, as I already said, it's the most effective and it has high success rate. Post-survival rate of embryo is around 35 to 90%, and implantation rates are also high as compared 8 to 30% as compared to the oocyte cryopreservation. Now I want to focus on a random protocol just to understand what is it. Usually what happens in a normal IVF cycle, we give induction drug to the patient for formation of the ovarian oocytes. And we wait for the normal menstrual cycle. We wait for the cycle and we try to give the drug in the cyclical form. So what happens is, if one menstrual cycle we give drug and that cycle we are not getting the good number of oocytes, so that cycle goes waste. So for cancer patients, especially for breast cancer patients, we cannot let that time delay. So what happens is, and what is being recommended these days, is the random start protocol. So for women who want to minimize the delay in treatment, there is now a strong evidence to give random start ovarian stimulation. That is, we do not wait for their menstrual cycle to schedule. We do not wait for their LMP for their next cycle to, we just start the ovarian stimulation as opposed to the conventional method. Now, there is also data that women may also safely undergo 2 rounds of stimulation. So there is no increased risk of ovarian cancer, as it was believed previously that increased ovarian stimulation might increase the risk of ovarian cancer, but it is not the evidence now. So you can give at least 2 rounds of stimulation back to back. That is also random start protocol. So for women with reduced ovarian reserve and who have dissatisfaction with the first round of oocyte retrieval, we can give the second stimulation to increase the oocyte yield and also to reduce the time for their cancer treatment. Then another method I would like to briefly touch is the immature oocyte retrieval. In this, we don't wait for the oocytes to mature, again to reduce the duration to start the chemotherapy. All these methods, we are trying to find a middle path so that we are not able to delay the treatment also, and we are able to get the good number of oocytes. So one method is we retrieve the immature oocytes and we grow them in the in vitro media. We grow them in the media with various growth hormones and proteins, and we observe their growth. So retrieval of immature oocytes followed by in vitro maturation allow the women to avoid ovarian stimulation also. So in this method, what is the benefit is that the women is not getting a lot of exogenous hormones also. We take the immature oocytes and we give the hormone stimulation and all the proteins and hormones in the artificial media. So the women is also saved from the unnecessary ovarian hormone stimulation. But again, this is a very good method, but still not very much into the practice these days. It is still in the experimental stage. Last is the ovarian tissue cryopreservation. When we know we don't have time for ovarian stimulation, we don't want to wait, patient is already reported late to us. So what we can do is take a thin strip of the ovarian tissue and freeze it, place it in the storage. This tissue is later thawed after evaluation of the malignancy and everything, and we can transplant it to the patient's body, either at the orthotopic side or the head. Orthotopic is basically at the origin, that is in the ovarian fossa or the broad ligament, or heterotopic extra pelvic areas. So both these function, they restore the ovarian function into around 2 to 9 months, and ovaries are able to function, and then you can give the ovarian stimulation or the hormone for the oocyte production. So basically the idea of cryopreserving the tissue is that ovarian cortex, it is more resistant to cryo injury than the mature oocyte. So mature oocytes, when we preserve them, they are still more risky, they are more sensitive to the cryopreservation method, whereas when we take the whole tissue, it is believed that it is more resistant to the cryopreservation methods. So it can be used in patients who do not wish to have ovarian stimulation hormones and do not want to delay the treatment. And the benefit is, but the current evidence says that it should not be used as a sole method. It can be used as a dual method with some standard technique as a backup method. So it can be kept as a backup method to the standard technique what we believe to the according to the current evidence and current guidelines, that the embryo and the oocyte cryopreservation is the best technique. So the current status of ovarian tissue transplantation is there are a lot of questions which are unanswered regarding this. That is the where to implant that, or is there is a chance of malignant transformation in the ovary? It's an invasive procedure. Then how much should be the size of the graft? So a lot of unanswered questions about this procedure, but still it is very much in research, and we might be able to answer those questions in future. So in summary, I would just like to conclude that embryo and oocyte cryopreservation, they are the most reliable method. Embryo cryopreservation has a high success rate. Then ovarian tissue cryopreservation is still not a standard method, but it has led to around 131 pregnancies overall, restoring the ovarian function and not involving, of course, the ovarian stimulation. GnRH again are being studied for ovarian suppression, but inconsistent result. And very importantly, the female breast cancer patients are being poorly counseled regarding the negative impact of treatment on their fertility. So proper counseling and timely involvement of the fertility specialist has to be there in the final decision making. That's it. Thank you.
Thank you very much, Shubham, for an excellent talk, because, I think, this kind of clarity is what I'm sure all the students, and even if you ask me, it has, cleared up my mind also about various aspects of fertility preservation. And I can see Dr. Vineeta Goyal, who's a senior radiation oncologist at Fortis Shalimar Bagh, wanting to ask a question. Dr.
Yes,
Vineeta, please go ahead.
Dr. Shubham, thank you for a wonderful presentation. I have a very basic and maybe stupid question to ask. So suppose ovarian tissue is preserved and is transplanted back.
Yes, ma'am.
Then how will the oocytes reach the fallopian tube and uterus?
No,
because
ma'am.
you're saying that it
Yes,
can be
yes.
implanted anywhere.
Yeah, ma'am. I have an answer to that question. The point is, we implant it only with so that it has its own blood supply. We are able to stimulate and we are able to retrieve the oocyte. They will not travel on their own. We'll have to do an IVF after that.
Okay, understood. Thank you.
We'll have to do an IVF. It is just that it has its own blood supply and it can produce its own oocyte. It's in the patient's body. So they are accepting, okay, it's coming from my body, but then they will not reach on their own. We'll have to do an IVF for sure.
So I'm
Thank
sure
you.
one of the questions that always bothers us is, how long is it going to take? What is going to be the delay? And, fortunately, we have been through this time where it used to be 1 month and now it takes about 2 weeks for an induction, because now, like you said, you do a random start protocol.
Random protocol, yes, ma'am.
Yeah, so that is one of the questions that Dr. Sushant has asked, and I think we are more comfortable now referring patients to fertility specialists. Patients are more comfortable knowing that 2 weeks is not so much, and it is. Thank you very much again for an excellent.
Thank you so much.
I'm sure all of us have benefited from it. And now I call Dr. Kavita back to see if her slides are able to move. Dr. Kavita, for the pathology pointers, and very quickly, because,
Yes, ma'am. Actually, they have to allow me to share the screen.
Nidhi, is Kavita allowed to share screen? Yes,
Yes,
Yes, ma'am.
Thank you.
Ma'am, can you see the screen?
This is a word picture that we're seeing. We're not seeing a PowerPoint.
Now can you see?
No. So what you do is, I suggest that you send your PowerPoint to Nidhi, and she can run it for you while I call upon the next speaker.
Sure, ma'am.
So why don't you send it to Nidhi? Yes. So in the meantime, let me. Okay, now we can see something. Yeah.
Yes, ma'am. Now you can see.
Yeah. Yes. Just click on the first slide and you can go ahead.
Now you can see.
Yes. It's
Now it's moving.
Yeah.
The first slide. We're not at the first slide yet.
It's moving now. From my side, it's moving, ma'am. It's not moving.
No, it's not moving. We are not.
You send it to Nidhi. Yes, you send it to Nidhi.
You send it to me.
I'll just send it to me.
Yeah.
I was thinking why we can
Okay, so one other aspect which is very, very, very important, and it is gaining more and more prominence. Today we talk in terms of triple negative breast cancers, but now there are new recommendations coming for all cancers under the age of 50, and for for triple negatives under the age of 60, 65, all have to undergo genetic, are recommended to have genetic testing. But mind you, genetic testing sounds simple, is available over the counter, but I want to take this opportunity to impress upon the young minds that it is not only about genetic testing. There's something called pre-test counseling and post-test counseling. And to talk more about it, we have Dr. Charu, who's from MedGenome and is a genetics specialist. And she is going to tell us, what is the importance of all these terms that I just used, and she's going to throw light on it. Thank you, Dr. Charu, for joining us, and please take this.
Thank you so much, Dr. Geeta and everybody. It's a great learning session for me as well. So particularly coming to genetic testing in TNBC, as we know, Dr. Geeta just said, it is not just about the testing. There is a lot of pre and post test decision making and the counseling and everything which goes into actually goes into it for providing the best amount of benefit that the patient can have out of this exercise. So as we know, already discussed that TNBC kind of an aggressive phenotype, and breast cancer includes almost 13.5% of the whole cancer burden, which was reported by Globocan 2020 in India. And triple negative breast cancer have an aggressive clinical course, and they particularly are an aggressive subtype, which is highly prevalent among the Indian women and occur in almost 20 to 30% of the patients. Moreover, 15 to 25% of all TNBC patients can have a germline, which we say an inherited BRCA1, BRCA2 mutation, which actually makes it more aggressive, and it comes with the treatment modalities as well as a good amount of repercussions for the familial cancer burden as well. So around 60 to 80% of patients carrying a BRCA1 germline mutations are characterized by TNBC phenotype. So if we say per se a family has a BRCA1 mutation running in their generations, so 60 to 80% patients have a risk of developing TNBC in that particular category, specifically for BRCA1. As compared to if we look at BRCA2. So interpretation of results depends upon the genes, depends upon the variants, and depends upon the kind of testing you are doing and how the patient is counseled. So as we can see, BRCA1 and 2 germline testing is basically to why this testing is done. Firstly, we need to understand that. So it is done to have hereditary risk assessment. For example, to understand presence of personal or familial history of cancer, how it helps in analyzing what is the risk of a patient, because any asymptomatic individual having a germline BRCA1 or 2 mutation has a chance of 50 to 60% chance of developing breast cancer and 45% chance of developing CA ovary, and definitely it impacts on the overall survival of or survival rate of these patients, has a theragnostic value, deciding the best drug treatment, increased sensitivity towards platinum and PARP inhibitors, which is now coming in early breast cancer as well. So early breast TNBC cases where you're going for surgery, there also the germline BRCA screening is becoming more and more important, so as to decide the course of adjuvant treatments. And definitely it is recommended by all the important guidelines. So these are all the important rationales of BRCA1, BRCA2 testing. So other than that, there are several other genes which are related to moderate risk and low risk, like ATM, PALB2, because these are genes which have a little less penetrance as compared to BRCA1, BRCA2, but they actually have almost similar kind of effect, and it has implication for other family members which are not straightforward. So that is where your counselor comes in and gives the family a very clear perspective sensitive, because there could be any kind of mutation which is either a VUS, which is a variant of unknown significance, not being reported earlier. So those kind of modalities do kick in, and that is where a role of a geneticist or a genetic counselor comes in to dictate your clinical decision, not only for the patient but also, for example, for the family. For example, if we take an example of PALB2 gene mutation, which is not BRCA but kind of a similar pathway where PALB2 functions. So the actionability is, it is a moderate risk, and but it is good enough to give you a clarity that the patient needs, the family will need enhanced survival, enhanced surveillance. And it is also important to screen, to treat the patient as a moderate risk in terms of having secondary malignancies. So those kind of modalities come with each different mutation. So just the gene is not important. The kind of mutation that comes in the gene is also very important to be interpreted by correctly, and that interpretation has to be inculcated in the mind of the patients in a very, very proper manner, giving them all the pros and cons of what this mutation actually means. So those kind of things are essentially documented, or you can say are given out by the counselors who are trained and who are actually meant for explaining those results to the patients in a very formatted and a judicious manner. So if you look at who should be tested. So basically, earlier the thing was that any breast cancer patient diagnosed at the age of at or before 50 years, multiple primary cancers in either one or both breasts, case of a male breast cancer, and triple negative in itself is a essential risk factor. So there is no age limitation as far as you can see for triple negative. So any triple negative cancer patients who is detected at any age, irrespective of age, has to be screened for having any inheritance mutation, because triple negative itself increases your probability that this could have certain inheritance component in it. So these are the latest guidelines which are available in terms of selecting the patients who should be tested. Now coming to a very another concept which is coming up, what is the clinical utility of universal germline testing. So any patients with any kind of breast cancer, we say that this kind of testing is called testing for unselected individuals. So here we are not typing out the individuals on terms of their family history or age or type of breast cancer. So this study had just come recently in the late 2022, where they actually did a study of 952 patients, and they did not keep a criteria of NCCN guidelines. So basically they tested each and every individual who was detected with breast cancer, and there were some great results which were found that there should be no restrictive criteria for germline testing, and because it clearly changes the clinical management. So clinical recommendations for almost 68% of the patients who did not meet the criteria were found to have pathogenic variants in cancer predisposition genes. So this kind of finding has actually made the clinicians to understand that this testing is beneficial for almost 2/3 of the patients with pathogenic variants, and for 1/3 of the patients where either negative or VUS results were found. So wherever you find negative results or VUS results, there is de-escalation of surgical intervention, and wherever there is pathogenic and positive results, so there is a enhanced aggressive approach of treatment is to be done. So clinicians had to make a total of 132 changes in the clinical management. of patients having pathogenic variants. So this is a detailed study which was published in JAMA Oncology. Coming to American Society of Breast Surgeons, this is the recent recommendation which says that it should be a universal germline testing, has the potential to impact many patients, and almost if you are testing all your patients, then it definitely increases your probability of having a better treatment outcome. So that is what is now established by American Society of Breast Surgeons as well. So this is a very important data, which is an Indian data, which is published by some great at AIMS particularly. So if you look at this study, the testing was done on basis of NCCN criteria and then unselected individuals. So before the patients were selected, there was pre-test counseling where a multi-gene and NGS panel was given to the patients, and if you look at the results, 14% women had positive family history and 35% of them had triple negative breast cancer. And if you look at the percentage positivity, almost 18.64% women were having likely pathogenic or pathogenic mutations, and more than 95% sensitivity was achieved for all women up to 60 years of age were tested. And if you look at the cascade testing, so almost 31 of the previous families, that means 16 out of 44 families were tested positive with the cascade testing. So what is cascade testing is I'm going to explain in the next slide. Now, if you look at how we go with the family studies process, so particularly a family comes to a counselor, they join the study, and particularly they will collect the additional family information, which includes the age of onset, the whole pedigree analysis for the patient, and other aspects of basically such as onset of menstrual cycle, onset of breastfeeding, onset of giving birth. So all these information is collected, and then patient particularly goes to find the information of what variant was actually found in their report. And if it is a VUS, that is a variant of unknown significance, which has not been reported before, then the lab will, in collaboration with the lab, the counselor will help them to send samples for other family members so as to establish the information of that particular variant, because there might be other affected family members who have the same kind of variant. So it is important to undergo a proper pedigree analysis before stepping up into the process of testing and coming to a conclusion. So what are the major aspects of genetic counseling? So the first step is to go for a pre-test counseling, where you discuss the benefits and limitation of genetic counseling. You give them important ideas about what is the explanation of positive result, how this will impact their management, and importance of testing the affected individuals, what will be the cost, and other legal and social implications. So a very important point is to give them a great idea about social implications in case of patients family member testing, so where the asymptomatic individuals are getting tested, social implications, and other fertility related issues, and how it will impact their family. So all those things particularly the counselors keep in mind, and they give them a very crude idea about everything. And then once the patient is agrees for the test, once the report is out, obviously the clinician plays an important role to look at the report and look into the clinical management of it. But before that, it is important to understand that what variant has been reported, whether that variant or whether that gene which is having this variant is low penetrance gene or a moderate penetrance or is a high risk gene. So after that, the thing is to understand whether this variant is actually pathogenic or having importance in modulating the disease modality for the particular family. So then you have to review and discuss the test results with a geneticist or a genetic counselor and determine the management on basis of that. So determining whether testing is going to be appropriate for other family members or not, so that comes into play. And also providing the supportive counseling. So all these things in terms of selecting the medical management, communicating the strategy of coping, how to cope up with such situation, and how to normalize such kind of results, so that there is no uninformative or any such panic or anxiety situation that can kick in because of these results. So it is very important to actually discuss the benefits, limitations, and risk of the testing before a patient jumps into a counseling. And after the result is out, all those aspects which I just discussed have to be provided very clearly to the patient. So that, I think, until unless this is done, the purpose of the testing is not solved, because unless the patient understands it completely, this genetic test for the family members is just going to play like a piece of paper. So why it is becoming more and more important to actually reduce the cost of testing, because cost of testing to benefit of treatment ratio is very high. So if in India we look at the cost of testing right now, which is getting reduced day by day, and the testing, when it becomes more cost effective from a societal point of view and from an insurance point of view, the cost effective benefits actually are based on advantages that there will be selective the preventive therapies are much more beneficial as compared to actual treatment and a patient under developing the cancer. So from a preventive oncology point of view, the cost of testing to benefit ratio is very benefit is very high. And there will be earlier risk reduction in interventions such as selective estrogen receptor modulators, chemo prevention, risk reducing mastectomies, and risk reducing oophorectomies. Definitely all those fertility and in terms of family planning and all those aspects kick in, and that is where your genetic counseling part comes in. Triple negative being early onset and aggressive form of breast cancer definitely needs more aggressive and more prevalent awareness in terms of genetic testing, and not keeping it restricted to BRCA is also one of the major roles. Because if you look at this Indian data, which we published along with AIMS, you can see that 34% of the mutations were present in non-BRCA genes. So those non-BRCA genes also sometimes have great implications in terms of actually providing the the aspect of further treatment or further management for that family. So that is the end of my presentation, and I would be happy to answer any questions if there are any.
Thank you so much, Charu, for a very, very, very elaborate, in fact, just the thing that we need to know. So very, very important that pre-test counseling should precede the test, and post-test counseling obviously follows. And of course, the thing that you said about cascade testing, which is something that the clinician should impress upon the patient whenever she comes for follow-up, because lots of time there is no follow-up on what happens to the other family members, because that is where we need to get to. But I will not take questions from you, but there are questions in the chat box. If you could just look it up.
Yeah, I'll answer them.
And please answer them there. So because we'll need to move on, because we are really.
Correct. No issues. I will answer. Thank you so much, Dr. Geeta. Yeah. Thank you everyone. Yeah.
Thank you so much. So now let's move on to the next talk, which is the pathology bit. And I hope Dr. Kavita is now ready.
Yeah, I'm so sorry.
That's all right. But Kavita, make it very crisp.
I'll try to make it fast.
Yes, it has to be fast, because we're running short of time.
So if Nidhi can just share the screen.
Is the screen visible?
Yes. Okay.
Okay.
Slideshow.
Can you make it full screen? Yes. Slideshow. Play from start. Yeah.
Okay. So we move on to the next slide, Nidhi. So, okay, breast cancers, as we know by definition, they are negative for all the hormone receptors, estrogen, progesterone, HER2 expression. There is a considerable overlap with basal-like breast cancers, and initially people used to think that they are synonymous, but no, they are not interchangeable. The basal-like breast cancers are defined by gene expression profiling, and they are one of the subtypes of triple-negative breast cancers, constituting around 80% of the population. Next slide. Next slide. So whenever a pre-treatment biopsy comes to us as per the protocol, we generally describe, and as Naim said, there should be at least 5 pointers. So to start with, we give you the histologic type of breast cancer. Then we go on to the histologic grade. Now, histologic type is generally a pathologist would see how the cell looks like, whether it resembles a duct, whether it is squamous, whether it is spindle or etc. And histologic grade, we are giving on Nottingham histologic scores, where we include 3 variables, that is how much the tissue is forming a gland, how much the nuclear pleomorphism is there, and mitotic rate. So next slide. So as we can see here, this is a normal breast tissue where we have the larger ducts and the smaller acini. So if this is a tumor which is resembling the ducts very closely, we call, and we count all the variables, we find that there is no nuclear pleomorphism, there is less mitotic activity, it accounts to be grade 1. Then comes to grade 2, where we see some tubules, but the tumor has started solidifying and more nuclear pleomorphism. And here, if we see that the tumor has become solid, that is the high grade tumor or grade 3 with a lot of mitosis. Next slide. So majority of triple negative breast cancers are invasive duct carcinoma of no special type, and they are most commonly poorly differentiated. Next. So there is a spectrum of triple negative breast cancers on grading. There are low grade triple negative breast cancers, of course, and you can be asked in exams that adenoid cystic carcinoma, can you just name 2 low grade triple negative breast cancers? They are adenoid cystic carcinoma, which look like salivary gland tumors, secretory carcinomas, and low-grade adenosquamous carcinomas. And on this list, we have infiltrating duct carcinoma, NST being the most common, no specific type. Then we have metaplastic carcinomas like squamous cell, spindle cell, and then carcinoma with medullary features. So this is the histologic type and grade, which would help you, because low grade would be a good prognosis. Next slide. So a word on stromal tumor infiltrating lymphocytes. So they are an integral part of the tumor microenvironment, and they depict how a tumor is showing the immune response to the tumor microenvironment. Now, mostly it's not been practiced unanimously in all the biopsy reports. And although there are recommendations coming that they should be reported on each biopsy, whether it is a large tumor or a pre-NSCT biopsy. Next slide. So in breast cancers, molecular subtype definitely has a major influence on interaction with the immune system. And triple negative breast cancers and HER2-rich tumors they are mostly associated with higher TILs. The reason being that they are molecularly heterogeneous at genetic level, and they produce more neoantigenic load, and so they attract more immunogenic cells, and thus they have high TILs. Now, some time ago, breast cancers with dense lymphocytic infiltrate would call medullary carcinomas, but however, the name has now been changed to invasive carcinoma with medullary features. Next slide. So the use of TILs has a predictive, can be used as a predictive and prognostic biomarker. How? Next slide. In neoadjuvant setting, so there have been retrospective and prospective clinical trials like the JEPAR-2 and JEPAR trials, where high TILs have been associated with high pathologic complete response, which was again confirmed by some more trials. And then it has been seen that high TILs seem to gain an additional benefit from carboplatin treatment. Next slide. In adjuvant, there are several studies that show an increase in recurrence-free survival with increasing level of TILs. For example, in the adjuvant Pinher trial, every 10% increase of TILs was significantly associated with decreased distant disease-free survival. Next slide. Again, with the residual disease, they have been shown to be a significant association, and they have been shown to show a good improved outcome if there is an increased TIL in the residual disease. Coming on to the future perspective, next slide. So most importantly, I have been also working on this concept that most important question is which tumor may benefit from additional therapy, that is the immune modulating drug like anti-PD-L1s. So this TILs, if they are high in number in the tumor microenvironment, we can predict that the immunotherapy can work against these tumors better. Next. How do we measure the TILs? So next slide. The H&E stain is the most important method or the most routinely employed method for this. Next slide. Next, please. So it is a semi-quantitative method which is done routinely. It is time-saving and expensive. And we calculate the TILs on the H&E sections. Next slide. So this, if I can show you, these are the variable patterns of TILs. If you can appreciate, these are the tumor cells, and this is the intervening stroma between the tumors. The TILs can be appreciated in two compartments, that is within the stroma and the intraepithelial TILs. But mostly in routine reporting, we are going for stromal TILs, that is the TILs, the tumor infiltrating lymphocytes between the tumor cells. These are the stroma, and they are more reproducible and they are more abundant. Next. So some facts about the residual cancer burden. How do we calculate residual cancer burden post-NSCT patients? Next slide. The residual cancer burden index categorizes patients with breast cancer into 4 subgroups based on the level of residual disease. Now, it has a linear relationship with event-free survival at 5 and 10 years. Mostly the residual cancer burden is mostly, again, as I told you, that triple negative breast cancers and HER2 rich breast cancers are rich, they are immunogenic. So mostly we see a good response practically among these tumors. Next slide. So there was a pool data from 12 institutions with about 5,160 patients, which showed this chart. Next slide. So as we can see, the triple negative breast cancers, they have the maximum pathologic complete response and the minimal residual disease in the RCB3 category. So we give them as RCB1, RCB2, and RCB3. How do we calculate? Next slide. So this is a calculator available on online calculator available, where we calculate the primary tumor bed area along with the lymph nodes. We just put the values and just calculate, and we get the residual cancer burden score as well as the grade. Next. And this is the type of responses we get on the chemotherapy. The post-NSCT is we may get a complete response where we, your J wires or your clips may help us to locate the tumor bed, or we can see a partial response, which can be of 2 types. There can be a concentric shrinking of the tumor, where this was the initial tumor and it has concentrically shrinked, or it can be a scattered or honeycomb appearance of the tumor, where we have to section the entire tumor bed area meticulously to calculate the primary tumor bed size. Next slide. So the future is the molecular or the genetic or the molecular subtyping of triple negative breast cancers. Next slide. So earlier on gene expression mRNA profiling, the Vanderbilt classification, 6 subtypes of triple negative breast cancers were delineated: 2 basal-like, immunomodulatory, mesenchymal cell-like, and luminal androgen receptor subtypes. However, it was reduced by Baylor further on DNA and mRNA profiling into 4 subtypes. Next slide. So Broadly, it was divided into basal-like subtypes, mesenchymal subtype, and luminal androgen receptor subtype. So these are so we are also pursuing a study on defining a surrogate IHC markers to broadly classify them on IHC, because RNA and DNA profiling are really very expensive. We are also trying to standardize the types on the basis of IHC and comparing it with the DNA and RNA profiling. So basal-like subtypes, the basal-like one is immune activated and basal-like 2 is immune suppressed. So the basal-like one, they show the highest response rate to neoadjuvant chemotherapy. So why do we subtype them? Because they have different genetic makeup, and of course they have the highest response to neoadjuvant chemotherapy, and they are most likely to the BRCA gene. And mesenchymal subtype is associated with pigment pathway aberrations, and mTOR inhibitors are under investigation. The luminal androgen receptor subtype is associated with high AR expression and is mostly seen in elderly patients. So I feel that whenever the patient is, whenever elderly patient with triple-negative breast cancer comes to us, I think it should be a routine practice to go for AR IHC, the androgen receptor, which is easily available IHC biomarker with us, so that if the patient presents with a metastatic condition, we can go with some anti-androgen treatment. So they really have a great significance. So we are still evolving with the molecular subtypes or subtyping. Next slide. So BRCA and beyond. Dr. Charu has already spoken about it, but let me just concise it. Next slide. Next slide. According to the National Comprehensive NCCN guidelines, no, the earlier slide. Earlier slide. The BRCA1/2 testing is generally recommended for patients fulfilling high-risk criteria or those who are diagnosed with under age 60. But in unselected TNBC cases, the prevalence of pathogenic germline BRCA1, BRCA2 mutations is approximately twice as high as the overall cancer. And if we have two factors, that is early age and a positive family history, the BRCA mutation probability becomes up to 40% when both risk factors are considered. So in triple-negative breast cancer, majority are BRCA1 carriers and 25% of breast cancers in BRCA2 carriers. Next. So BRCA testing is done on NGS technology, which has high sensitivity, specificity, and rapid mutational analysis of multiple genes can be done. It is cost effective. We have two platforms, that is Illumina and Iron Torrent. At Max, we are doing on Illumina platform. And now it is recommended that NGS should be, either we make it a compulsion to do it with MLPA, that is a multiplex ligation dependent probe amplification, so that we do not miss large deletions and duplications, or we keep it as a reflex test. That is, if we find something suspicious on NGS, which may miss these large deletions and duplications, we can go for MLPA and we don't miss these patients. Next. So BRCA and beyond, there are limited studies which say, as Dr. Charu had also mentioned, that there are non-BRCA genes, as mentioned here, where they can be prevalent in women, and they can, specifically there have been various studies like 17 breast cancer genes that were found in 11.2% triple-negative breast cancer patients, and around 3.7% had mutations in these genes. Next slide. Again, another study by Shimilis et al. Proved that the BRCA1 mutations are the major contributors to early onset TNBC, while the other genes made a large proportion over age 50, irrespective of family history. So it is therefore possible that current guidelines for genetic testing is insufficient for carrier screening and should be expanded to include other predisposition genes also. Next slide. So expansion of genetics testing guidelines and clinical risk assessment is required. That may help identify patients who can benefit from targeted therapeutic strategies. Thank you.
Thank you. Thank you very much, Kavita. Again, an excellent talk. I'm sure, a lot of things have come into the fore because, things that are not discussed very frequently, like TILs and residual cancer burden, which can make your conversation with the patient very robust and meaningful. I think we have achieved that with your talk. So these were the pointers, we wanted to keep it brief, but, I didn't want to interrupt them also, because I think, learning is something that, the more we talk, the more we learn. But of course, it does take up a lot of time also. Now we're coming to the peachy bit of proceedings, because now we're going to have talks from our younger colleagues. So to take you through the surgical, medical, and radiation bit, I would now invite Dr. Ritu Thakur, who is who's a MCH, who's pursuing her MCH surgical oncology in AIIMS, and she's going to be talking about the surgical considerations in negative breast cancer, because every time we open our mouth, we have a lot of discussion and arguments happening. The moment a surgeon steps in to say anything, there is a medical oncologist trying to hush him or her down. So I think, we should not be leaving ground. There is a need for each modality, and it is not really time up for surgery. So let's hear what Dr. Ritu has to tell us in terms of the various surgical considerations for triple negative breast cancer. So Dr. Ritu Thakur, over to you.
Yeah, thank you, ma'am. My screen is visible, ma'am?
No. Not yet? Yes.
Visible.
We got a glimpse of it and then it disappeared. Try another time.
Yes.
It's gone again. Came and went.
Okay.
Have you got your presentation on your
mail? Like, ma'am, I have mailed to Dr. Preeti, ma'am.
So Preeti, can you please share screen? Are you able to open it?
Ma'am, Nidhi is doing it. I've already.
Okay. So I
She's doing it in the
have
moment.
it.
Ma'am,
Wait a
I
second.
just received it. I'll take.
I've got it. Let me just do it. Okay. Just a second. No? I'll have to share screen. Just a second. Can you see it?
Yes, ma'am.
Yes, ma'am.
Okay, great. So Ritu, go ahead.
Okay, ma'am.
And everybody else mute themselves, please. Thank you.
Very good evening to all. Myself is Dr. Ritu Thakur. I'm MCS trained in Department of Surgical Oncology, AIIMS, New Delhi. And I'll be speaking about TNBC from surgeon's perspective. Next slide. When we talk about the definition, according to ESCO and guidelines, triple negative breast cancers are those cancers that have less than 1% expression of ER and PR immunostaining, or they are HER2 either 0 or 1+ positive, and if they are 2+, then FISH negative. Talking about the triple negative breast cancer in broad terms, it accounts for 50% of the breast cancer worldwide and is commonly diagnosed cancer in women younger than 40 years. When we talk about the BRCA mutation, it has been reported in around 20% of the TNB patients and has in African American race, there is a high predilection. When we talk about the salient features about TNBC, it is heterogeneous in presentation, primarily because of the various molecular component it enwraps. That is the types of molecular subtype is that like mesenchymal, immunomodulatory, claudin low, liminal hydrogen. Because of this, the presentation is heterogeneous and as the response to chemotherapy and surgery. These are the tumors who are most likely to be diagnosed clinically, and the most common histology is the infiltrating ductal carcinoma. They mostly present as high grade with aggressive biology and high chemosensitivity. When we talk about neoadjuvant chemotherapy, it has been broadly, the indication has been broadly grouped into two. When the tumor is locally advanced, or we want to facilitate the breast conserving surgery in those who are not the ideal candidate. So the conventional indications for NACT in all the molecular subtypes or in all the breast cancer is either the node positive disease, stage 3 disease, T3 or T4 lesions. But if we speak about TNBC, a neoadjuvant chemotherapy, TNBC, as we all know, they have high clinical and pathological response to chemotherapy. So it facilitates the cosmetically acceptable surgery, which results with downstaging or the downsizing of the tumor. It also allows the tailored approach to systemic chemotherapy after the surgery. So we all know that in TNBC, the upfront or the first approach to the treatment part is the neoadjuvant chemotherapy. But if we talk about the upfront surgery, does it has any role in TNBC? So we have some evidence. When we compare the long-term outcomes for neoadjuvant chemotherapy versus adjuvant chemotherapy in early breast cancer, it was a meta-analysis from 10 randomized trial. It has included around 4,756 patients. It compared both the neoadjuvant versus the adjuvant chemotherapy. It reported that there's an equivalent risk of distant recurrence and breast cancer mortality, whether you're giving neoadjuvant chemotherapy or the adjuvant chemotherapy. But there was increased risk of local recurrence, but that was reported at the interval of 15 years. However, there was increased frequency of breast conservation if we are doing in the neoadjuvant period. These are the two trials, NSBP 18 and NSBP 27. Both has reported that there is no survival benefit when you're giving chemotherapy either in the neoadjuvant setting or the adjuvant setting. And there's no significant difference in the disease-free survival or the overall survival. So what is the management of a small TNBC tumor? Still, the potential benefit of chemotherapy has remained unclear, but in a study from MSKCC, which has included 194 TNBC patients, the loco-regional and distant recurrence-free survival in the early tumors, that was T1A and T1 tumors, were similar, and there was no difference in the outcome based on the recipient of chemotherapy. There was another cohort study done with the NCCN. It has reported, it is primarily done for 4,013 patients in TNBC patient. The 5-year distant relapse-free survival for T1A tumor was 93% without chemotherapy. And for T1 tumor, it was 90% without chemotherapy compared with 96% with chemotherapy. Next slide. So the question arises whether what should be the treatment, whether we should go ahead with neoadjuvant chemotherapy or whether should we go ahead with the upfront surgery. So somewhat it has been answered by this article, that is the management of early stage triple negative breast cancer. It is there was recommendations from the Brazilian Society of Mastology, and it has reported it included the panelists and the affiliates, and according to 96% and the 83% of the affiliates, they considered that if the no incon tumor is achievable, then it is considered, if according to them, no incon tumor is, if no incon tumor is achievable, then we can proceed with the if the patient if adequate surgical margins are achievable, then you can go ahead with the upfront surgery. But that was reported only for the early breast cancer. This is another article in which the breast conserving which showed that the breast conserving therapy achieves local regional outcomes compared to mastectomy in women with early triple negative breast cancer. This was a retrospective study of 1,200 patients at the MSKCC in the T1 and T2, but node negative TNBC. And in this, the patients who underwent BCS was compared with total mastectomy, and the results were the results were compared, and there was no significant difference noted in the local recurrence, distant metastasis, overall when we talk about the paradigm change in the management philosophy of breast cancer, it has been progressed from era of radical therapy from 90s to 1980s. 1980s era is an era of precision medicine and is going towards the personalized treatment. The current focus, when we talk about the current focus, it primarily on the quality of life, cosmetic, and the aesthetic outcomes. Next slide, please. So the factors which contribute for the change in treatment approach is the better understanding of tumor biology, awareness, screening, downstaging of tumor, advances in imaging, advances in systemic therapy, advances in radiation therapy, clinical trial, and finally surgical leadership to go ahead with interception and willing to change. So the current surgical thought process is, when we encounter such TNBC cases, we have to ask some particular questions. Can we avoid a mastectomy? Is an upfront margin negative BCS is feasible? Is breast oncoplasty required? What type of breast oncoplasty can be done in such patient? And what other options can be available? NACT. If we are doing mastectomy, is there any feasibility of breast reconstruction? And the conservation and reconstruction are the default options that can be offered to the patients. And the last resort should be the mastectomy. There's an article published in 2000 which shows the 20-year follow-up of a randomized study which compared the breast conserving surgery. Previous slide, please. Which compared the breast conserving surgery with radical mastectomy for early breast cancer. It highlighted over a period of 20-year follow-up, there was no difference noted between the breast conservation surgery and mastectomy. Next slide, please. The other article is about is oncoplasty breast conserving surgery oncologically safe? This was an analysis of 18,000 patients. Next, please. This was an analysis of 18,000 patients, and the primary outcomes were included for the recurrence. There was, and they assessed the primary outcome in terms of recurrence, and there was no difference noted between the oncoplastic breast conserving surgery simple breast conserving surgery or the mastectomy. The secondary outcomes reported were the reoperation rate, and initially it was significant in the oncoplastic breast conserving surgery, but after the publication bias adjustment, it was found to be insignificant. So the conclusion of this article was, it is safe to establish oncoplastic breast conserving surgery as useful option or the other option for the if the patient is suitable for the surgery. So so far we have gone through whether the patient can go ahead with, we need to see whether the patient can go ahead with breast conservation surgery or the mastectomy. But there are different challenges that we notice in TNBC patients. The first and the most important is the TNBC has an aggressive biology, and around 20% of the in 20% of the TNBC patients, positive BRCA mutation status is found. Apart from that, if we talk about imaging, around 18% of the TNBCs are occult on initial mammography, with absence of calcification is noted in around 49 to 100% of the cases on mammography. So it is difficult to identify the occult risk of tumor. Apart from this, there is a risk of loco-regional recurrence, which is very high in TNBC cases in the first 3 years. And if the patient is BRCA mutation positive, then whether there's a need for contralateral mastectomy or the risk-reducing surgery. These are the specific challenges that that a clinician can see while operating on TNBC patient. So TNBC is not a sole indicator to go ahead with mastectomy. There are other factors that we need to determine while opting for the surgical option, that is the multicentricity or the tumor size. According to Bayomi, as we all know, that the common concept in TNBC cases is mostly we opt for mastectomy, and the same has been reflected in the various studies. According to Bayomi, the ratio of mastectomy versus BCS was 60%, and that was in favor of mastectomy. There was another study by Atkins, FC et al., who included 1,325 patients with TNBC, and reported that the mastectomy rate was high, that was 51% as compared to 49% of organ preservation. And in another study, there was no difference in loco-regional recurrence between, this is another study which is showing that whether we opt for breast conservation or mastectomy, there is no difference in loco-regional recurrence. If we opt BCS, if we select the suitable patients with post-operative radiotherapy. This is reflected in this study when multivariate regression was applied. In another study, Bigley et al. Found that there was no significant difference in the overall survival between the breast conserving surgery and mastectomy among BRCA mutations. This article primarily includes the BRCA mutation carrier, because in BRCA mutation, we need to, apart from operating on the index tumor, the contralateral mastectomy or the contralateral breast has to be addressed. This article addressed that there was no significant difference in overall survival if we opt for breast conserving surgery in BRCA mutation carriers. But they did, please go back. But at the follow-up of 15 years, they reported that the risk of local recurrence was 23% for breast conservation surgery and mastectomy. But this was about local recurrence. So if we opt for breast conservation surgery, what all factors we need to consider before operating a TNBC or a general or any breast tumors with any other molecular subtypes? The first and foremost thing is the tumor localization, size of tumor, careful instrumental study of the spread of the tumor, whether it is localized, segmentally extended, or irregularly extended, tumor to breast size ratio, age of the patient, comorbidities, probability of reoperation, contralateral reshaping, presence of donor sites for flap, patient choice, which is the first and foremost requirement for going ahead with any surgical option. Patient choice is an expectation, and the informed. Coming to oncoplastic breast surgery, what options we have? When we talk about the early breast cancer in Western world, when we talk about early breast cancer, more than 80% are early breast cancer. And if we talk about Indian scenario, only 40% to 40 to 50% are the early breast cancer. And to overcome shortcoming of breast conservation surgery, the deficiency of glandular tissue and skin retraction, reduction of ptosis, asymmetry of inframammary crease, and NSC retractions can be done. And the goal of oncoplastic breast surgery should be the complete removal of tumor, that is no incon tumor, attaining clear margins and excellent cosmesis. These are the single 3 factors that determines the locoregional recurrence or the local recurrence or the survival of the patient, especially in TNBC patient. Coming to the timing of reconstruction, it can be done at the time of breast conserving surgery, after a few weeks or 1 to 2 years afterwards. At the time of breast conserving surgery, it should be immediate, and it is immediate. And however, the surgical time may be lengthened because of the secondary procedure for reconstruction. And if complication occur, it may lead to delay in adjuvant therapy. If after a few weeks it is planned, it can be planned after a few weeks with assessment of the defect created or the deformity created, or if we are planning the contralateral symmetrical procedure, or it can be done delayed when it is done after a month or years. It has been broadly divided into volume displacement and replacement. Volume displacement is when it has been divided primarily into simple and complex. When there is a 20% volume loss, it is level 1 oncoplasty. And when there is a 20 to 50% volume loss, it falls under level 2 oncoplasty, that is complex procedure. The complex, while operating, if you notice that there's a 20%, up to 20% volume loss, level 1 oncoplasty or simple procedure can be done at the same time at the breast conserving surgery. And if while doing breast conserving surgery, there is expected loss of 20 to 50%, the complex procedure, level 2 procedure can be planned. The other procedure is the volume replacement, in which the various flaps, local flaps can be used, which include the LD flaps, TA flaps, LICAP, MICAP, or the implant reconstruction. These are the broad terms, and this is a broad view of what all procedures can be planned depending on the quadrant of the tumor location. Please go back. Yeah. These are the various quadrants that has been defined, and according to that, the various procedures has been defined. This is an atlas of techniques of oncoplastic reshaping, and the procedure can be planned beforehand before proceeding with the complex oncoplastic procedure. Next. And finally, the patient reported outcome. This is an what we can say is the patient reported outcome is the most important factors, which depends on the at the first step, when the patient enters into the OPD, the patient reported outcome is something which is the patient expect at the time the patient enters. Yes. Okay, please go back. The patient reported outcome is something which is very important while doing oncoplastic surgery, and I have quoted 2 articles. The Ujala et al. Has included 293 BCS and 86 OPS patients, oncoplastic breast surgery patients, and they have reported the breast cancer treatment outcome scale for assessment of aesthetic outcomes, as they have reported that the aesthetic results were better in the BCS only patients, but over the time, the oncoplastic procedures have the similar outcomes. There is another Keleman et al. Reported 350 OPS and 350 BCS and has reported at 1 year after surgery, OPS reported significant with better quality of life outcomes, including emotional and social functioning and body image. And these are the things, the quality of life and the patient expectations that has been reported in the patient outcome. So while considering surgical option, whether to proceed with breast conservation or the mastectomy, we need to consider the patient expectation, and apart from that, the BRCA mutation status and genetic status, or the tumor status, whether the tumor, to what quadrants the tumor is localized, what is the tumor breast ratio, and what patient expected from a clinician.
Thank you, Ritu. Very elaborate. So, as students, I know, there's so much to talk about, and you have covered a lot of ground. But I think, the technicalities of surgery is for another day possibly. But yes, you have covered a lot of ground. The whole basic idea as to how do we sequence treatment, you brought that out very well. And I think that is where the actual the essence of your presentation was. Thank you very much for a very, very elaborate presentation. So I will now request my further speakers to just try and stick to time, because we have overshot time already, and I'm sure people must be losing patience, and we really want to hear out what Dr. Harpreet has to say. He is DNB Medical Oncology resident at Max Hospital, Patparganj, and he's going to take us through the medical oncology aspect of triple negative breast cancer. I'm sure he's got something very interesting to say. Dr. Harpreet, over to you.
Thank you, ma'am.
Dr. Harpreet, are you able to share your screen? Dr. Harpreet, can you hear me?
I think so. He's kind of offline or something. I don't know. He's not reacting at all.
Has he got frozen? I think he need to rejoin or something. Dr. Harpreet, are you there?
Let us proceed with the radiation oncology talk.
Yes, let's proceed with the next one. I think Dr. Harpreet has possibly got stuck somewhere. So let me call upon Dr. Amita then, who's going to give us the radiation perspectives. Oh, Dr. Harpreet, are you there?
Yes, ma'am. Actually, I'm not been trying to share my screen. I'm trying hard, but it's stuck.
Okay. So
I
keep
think so.
trying and possibly
Dr.
send your presentation to Nidhi, and maybe she'll be able to help you.
Okay, ma'am.
In the meantime, we'll get our radiation oncology colleague to speak. Dr. Amita Prakash from Dharamshila takes us through the radiation perspectives in early TNBC. So Dr. Amita, if you're there, can you share your screen, please? Dr. Amita, are you there? Yeah. Oh, Dr. Harpreet has been...
Ma'am, is my screen visible?
Yes, I can see your screen. Make it full screen, and please, you have 15 minutes.
Okay, ma'am.
So very quickly, yes. Can you make it full screen, please?
Yes, ma'am.
Bottom right.
No, it's not.
Here.
Or sir, you can press on the slideshow button on top as well. Yeah, just next to the animation. You can click on slideshow, sir. Go
Just
to
next,
your right.
next.
No, actually.
Yeah, there,
bus.
there, just there. You can press play from start. The button on the left. Yeah.
Yeah. Okay, good evening, everyone. Topic for my today's talk is medical perspectives in early triple negative breast cancer. So triple negative breast cancer, as we all know, they are devoid of estrogen receptor, progesterone receptor, and HER2 receptors. And TNBC, it comprises approximately 15 to 20% of breast cancers, and they generally exhibit poor clinical outcomes. BRCA mutations is seen in nearly 20% of TNBC patients, 16% of which are BRCA1 mutations, and 4% are BRCA2 mutations. So as we have already discussed, triple negative breast cancer is a heterogeneous disease. Some of the important subtypes, they are basal-like subtype 1, basal-like subtype 2, mesenchymal subtype, and then luminal androgen receptor subtype. So what are the challenges with treatment of TNBC cancer? First of all, it is an aggressive disease. It is commonly seen in younger age group and heterogeneous disease. And still there are controversies regarding ideal treatment in neoadjuvant, adjuvant and metastatic settings. And there is no targeted treatment available for non-BRCA mutated TNBC cancers. So distant recurrence following surgery is nearly 3 times after 1 year, as we can see in this graph. So the first part of this talk is neoadjuvant chemotherapy. So NACT is the standard treatment for early stage triple negative breast cancer. Achieving pathological complete response is considered an essential prognostic factor with favorable long-term outcomes. So what is pathological complete response? It is complete disappearance of invasive carcinoma from breast and axillary lymph nodes. So for over 15 years, the use of anthracyclines and taxanes have been a standard approach for triple negative disease. So what is the role of adding platinum analogs in the neoadjuvant chemotherapy? So the landmark randomized trials, first of all, we have JAPR-60 trial, in which patients were enrolled into 2 arms. The first arm received only paclitaxel and liposomal doxorubicin, whereas the second arm received carboplatin, bevacizumab, along with the standard chemotherapy, that is pacli and non-paclitated liposomal doxorubicin. So it was seen that pathological complete response was around 58% in the carboplatin arm, and it was less than 40% in the other arm. So this is another landmark trial, CALGB 40603. Here again, stage 2 to 3 triple negative breast cancer patients were enrolled into 4 arms. The last 2 arms, they received carboplatin-based chemotherapy. And again, it was seen that pathological complete response was around 60% in carboplatin arm when we compared only breast cancers. But when we added breast as well as axilla, the pathological complete response was 54% in carboplatin arm and only 41% in the other arm. So does addition of preoperative platinum improve survival outcomes in TNBC? In Jaipur 60 trial, 3-year disease-free survival improved with carboplatin, that is from 76.1% to 85.8%. But in CAL-GB 4063 trial, there was not any improvement in event-free survival. So basically the results are mixed from preoperative platinum trials in TNBC, but achieving pathological complete response is a good surrogate for long-term outcomes on a patient level. Now, this is another trial by Birsky et al., in which preoperative cisplatin was used in preoperative therapy in patients with BRCA1 mutations. And it was seen that pathological complete response was 61% in patients receiving cisplatin. So when to consider platinum analogs in daily practice, especially when we need rapid loco-regional control to increase resectability, and when there is highest risk of relapse, like in stage 3 and in very young patients, and also in BRCA mutation carriers. So what are the benefits of neoadjuvant chemotherapy? They facilitate breast conservation, and it can render inoperable tumors operable. Treatment response provides important prognostic information, and it identifies patients with residual disease at higher risk for relapse. It allows time for genetic testing, allows time to plan breast reconstruction in patients electing mastectomy, and it allows time for delayed decision-making for definitive surgery. Now, what are the cautions of using neoadjuvant chemotherapy? There can be possible overtreatment with systemic therapy if clinical stage is overestimated, and there can be possible undertreatment loco-regionally if clinical stage is underestimated. And there can be possibility also of disease progression during preoperative systemic therapy. So we have to be aware of all these cautions while using preoperative chemotherapy. Now coming to adjuvant therapy for stage 2 to 3 TNBC cancers. Landmark trial is CAL-GB 9344, in which node positive early stage TNBC patients were enrolled. And here we can see in the figure A, disease-free survival was statistically significant in the arm receiving paclitaxel. And this is another NSABP B30 trial. Again, node positive triple negative breast cancer patients were enrolled. This trial was basically used to analyze the difference between the sequential use of anthracycline with taxane and concurrent use of anthracycline with taxane. Here we can see that in figure A, when sequentially anthracycline and taxane were used, hazard ratio was less as compared to the other two arms when doxorubicin were used with taxanes and when concurrent anthracycline and taxane were used. So the overall survival and disease-free survival was better when anthracycline were used sequentially along with taxanes. So the possible regimes are anthracycline and cyclophosphamide followed by paclitaxel, anthracycline, cyclophosphamide followed by weekly paclitaxel, and then anthracycline with cyclophosphamide followed by docetaxel, and lastly FEC followed by docetaxel. So this is another trial, ABC trial. Here again, node positive or high risk, node negative, triple negative breast cancer patients were enrolled in two arms. So this trial was basically done to see the non-inferiority of omitting anthracycline from the adjuvant chemotherapy regimes. In arm 1, basically anthracycline were used in all the 4 subgroups A, B, C, D, and in arm 2, only docetaxel and cyclophosphamide used. So in arm 2, no anthracycline were used. So the primary endpoint was invasive disease-free survival. Secondary endpoint was recurrence-free survival and overall survival and toxicity. Total 4,156 total patients were enrolled, out of which 31% were triple negative and 59% were node positive. So what we observed in this trial, that the hazard ratio was 1.2 which exceeded pre-specified threshold for fertility. So basically, giving only taxanes without anthracycline was inferior. So the secondary endpoints in this trial, recurrence-free interval, it was again improved when anthracycline was added along with taxane, but there was no difference seen in overall survival. So what is the conclusion? Anthracycline along with taxane is preferable over to only taxane therapy, with caveats which include the absolute overall benefit appears to be small. Benefit appears to be more prominent in ER-negative tumors or ER-positive tumors with lymph node positive disease. And in some subgroups, benefit is quite substantial. So what is the optimal treatment for small, node-negative, triple-negative breast cancers? Basically, treatment options for low-risk disease, it can be either simple regime where we can give anthracycline along with cyclophosphamide, or taxane with cyclophosphamide and CMF-based chemotherapy, or we can give sequential anthracycline followed by taxanes. So the general practice in T1A disease, simple regimes can be used along, and also in T1B, simple regimes can be used, but in T1C, simple as well as selectively sequential approach to be used. Now coming to the maintenance strategy, the landmark trial in maintenance strategy is CREATE-X study design. In this stage 1 to 3B triple negative breast cancer, which were having residual disease after surgery and neoadjuvant chemotherapy, were enrolled into 2 arms. The first arm received capecitabine, and hormonal therapy was given if the ER and PR status was positive. Primary endpoint was disease-free survival, and secondary endpoint was overall survival.
Dr. Harpreet, have we lost you? You're muted.
Yeah. Can you hear me now?
Yeah.
So disease-free survival among patients in triple negative disease was 70% in capecitabine group and 56% in control group. And overall survival was 78.8% in capecitabine group as compared to 70% in control group. Now coming to the immunotherapy part. As discussed earlier by previous speaker, the presence of tumor infiltrating lymphocytes assessed by ISC is widely recognized as a predictor of good prognosis in both adjuvant and neoadjuvant settings of TNBC. The expression of immune evasion molecules in the tumor microenvironment, such as PDL1, has also been shown to influence TNBC prognosis. So the landmark trial is KEYNOTE-522. In this trial, neoadjuvant pembrolizumab along with chemotherapy followed by adjuvant pembrolizumab was compared with the standard chemotherapy. So in this trial, triple negative breast cancer patients with T1C, N1 or N2 status, or T2 to T4 or N0 to N2 status were enrolled in 2 arms. First arm received pembrolizumab along with chemotherapy followed by surgery, and then in adjuvant phase, they received pembrolizumab 3 weekly. And the second arm received only chemotherapy and followed by surgery, then placebo. So what were the results of KEYNOTE-522 trial? Event-free survival at 18 months was 91% in pembrolizumab arm, whereas it was 83% in placebo and chemotherapy arm. And the pathological complete response was 68.9% in those patients who received pembrolizumab and chemotherapy, and 54.9% among those who received placebo chemotherapy in PDL1 positive population. And disease-free survival was 84.5% in pembrolizumab arm and 76.8% with placebo arm. Now coming on to the targeted therapy in BRCA1 and BRCA2 mutated breast cancer, a landmark trial is done by Andrew et al., in which they gave adjuvant olaparib to the patients. So total 1836 patients were enrolled. Patients were having early TNBC with BRCA1 and BRCA2 mutation, and patients, they already received local treatment and neoadjuvant or adjuvant chemotherapy, and then they were randomly assigned to 1 year of olaparib or placebo. So it was seen that invasive disease-free survival, distance disease-free survival, and overall survival, all these three were statistically significant in olaparib arm. So coming on to the NCCN guidelines, in HER2 negative patients, preferred regimes include dose-dense anthracycline with cyclophosphamide followed by taxanes, then dose-dense anthracycline with cyclophosphamide followed by weekly taxane, and then we have taxane along with cyclophosphamide. And then as per Keynote 522 trial, we have preoperative pembrolizumab plus chemotherapy followed by adjuvant pembrolizumab. And then as per CREATE design, we have capecitabine as maintenance strategy. And then olaparib is given in adjuvant chemotherapy in TNBC patients. So the conclusion is TNBC is the most aggressive histological subtype of breast cancer. In view of aggressiveness and high failure rate, early TNBC mandates the use of NACT. Anthracycline and taxane form the backbone of neoadjuvant chemotherapy. And there is upcoming role and interest in the role of platinum agents. As per Keynote 522, there is established role of Keytruda or pembrolizumab to improve pathological complete response. And adjuvant treatment can be given with either capecitabine in BRCA negative and olaparib in BRCA positive triple negative breast cancer. In view of high propensity of BRCA related defects, genetic testing is mandatory in all age groups. Thank you.
Thank you, Dr. Harpreet, for very, very concisely touching upon the very, very important trials that have led to treating triple negative breast cancers the way we do today. So I would invite comments from the mentors for this medical oncology talk. Dr. Jyoti Vadhva and Dr. Rajat Saha are both on board. So your take on the current treatment guidelines for triple negative breast cancers.
Good job, Dr. Harpreet.
Thank you, sir.
On concising the entire thing. Yes, definitely the backbone of treating TNBCs is still chemotherapy. That's why we fear the TNBC subset the most, because we don't have any targeted agent to hit. So yes, but with probably more wider use of NGS, we might be able to find out a targetable mutation in the near future. Dr. Jyoti.
Yeah, so I would agree. Somebody needs to be muted. Yeah. So, TNBC for a medical oncologist also continues to be a challenging subtype. And we have heard today also that the knowledge, the previous speaker did, elaborate on all these studies and the agents which have evolved over the years. And the outcomes have definitely improved with the addition of newer agents. So we not only have now chemotherapy to deal with triple negative breast cancer, but we have seen the very impressively emerging role of immunotherapy and also PARP inhibitors. But a simple drug like platinum, and my own student would also touch upon our own data from the TMH, wherein simple addition of platinums to the chemotherapy did wonders for young patients with triple negative breast cancer. So the treatments have evolved, but it continues to pose a challenge, and there's a lot more to be done because the outcome of TNBC continues to be dismal compared to other subtypes. So a lot more needs to be done.
Thank you, Dr. Rajat and Dr. Jyoti. And we move on to the next bit, which is, the radiation perspective in early triple negative breast cancer. A lot of excitement happening there as well. So I'll invite Dr. Amita Prakash to take us through the radiation perspective quickly, and then we'll have Dr. Kanika's comments on it as well. Yeah. Can Dr. Harpreet stop share? Is Dr. Amita there? Okay. Please make it full screen and you're good to go. So Nidhi, can you unmute Amita, please?
Yes, ma'am.
Amita, are you able to see, able to speak? We're not able to hear you.
Dr. Amita is on unmute.
But I don't see any symbol on her.
I'll just check, call her and check.
Dr. Amita needs to check her audio settings because we don't hear her. Can we ask, in the meantime, ask Dr. Narayan to go for the important trials in triple negative breast cancer while she is able to.
Ma'am, she's unmuted, but
there's a problem with the audio. So she can log out and possibly log in again while Dr. Narayan takes us through the important must-know trials in triple negative breast cancers.
Hello, ma'am. Can you help?
She has
share
to
my...
stop share. Dr. Amita has to stop share so that you can share your slides. Yes. Go ahead, Dr. Narayan.
Okay.
So Dr. Narayan is a medical oncology, a DNB resident at Medanta Hospital, and he's going to take us through the must-know trials in early TNBC.
Good evening, everyone. Today I'll be presenting on key trials in early triple negative breast cancer. I'll be covering the topics like the chemotherapy backbone, role of immunotherapy, PARP inhibitors, and also approach to residual disease. First of all, I'll discuss about the adjuvant chemotherapy trials, as most of the data of chemotherapy has come from the adjuvant trials. ABC or anthracycline in breast cancer trials are series of 3 trials which have compared addition of anthracycline to taxane and cyclophosphamide backbone, and the combined analysis of 4,000 patients have been done, which showed that addition of anthracycline to taxane and cyclophosphamide chemotherapy has significantly improved the invasive disease-free survival. This also has proven that the survival was more pronounced in hormone negative subgroup, establishing the role of anthracycline in triple negative breast cancer. The next trial, CALGB 9741 trial, compared the sequential versus concurrent chemotherapy with doxorubicin, cyclophosphamide, and paclitaxel in either standard 3-weekly fashion or dose dense 2-weekly fashion. So the dose dense regimen was associated with fewer grade 4 neutropenia. It was also shown that the dose dense regimen was associated with higher disease-free survival when compared to standard 3-weekly regimen, establishing the role of dose dense regimen in adjuvant setup. The reduction in hazard was 32% in ER negative versus 19% in ER positive. So the benefit was more pronounced in triple negative subgroup. Then the intergroup ECOG 1199 trial compared different doses and schedules of taxane chemotherapy, which compared paclitaxel 3-weekly with paclitaxel weekly, docetaxel 3-weekly, and docetaxel weekly regimens. So in triple negative subgroup, weekly paclitaxel was associated with significant benefit in disease-free survival as well as overall survival. So this is the standard of care as a taxane backbone. Now coming to the neoadjuvant trials, JPAR-SEPTO, the phase 3 trial compared weekly paclitaxel with weekly nab-paclitaxel in the neoadjuvant setup. So this trial showed that there was significant pathological complete response rate benefit for nab-paclitaxel, which was 38% versus paclitaxel, which was 29%. The benefit was even more pronounced in triple negative subgroup, which doubled the PCR rate to 48% from 26%. So nab-paclitaxel also improved invasive disease-free survival, but overall survival was similar. In the subgroup analysis of triple negative breast cancer, there was trend towards significance in terms of DFS. So is the role of platinum? Multiple phase 2 trials have shown significant PCR benefit with addition of carboplatin, but we have 2 phase 3 trials. We have proven the benefit of addition of carboplatin in a phase 3 trial by Gupta et al. From Tata Memorial Hospital, which analyzed 717 patients of triple negative cancer into taxane anthracycline neoadjuvant chemotherapy versus addition of platinum with taxane. There was significantly higher pathological complete response rate, 5-year event-free survival, and 5-year overall survival in entire population. And when subgroup analysis was done, the benefit was even more pronounced in younger subgroup, which are less than 50 years, but there was no significant difference in the older subgroup, establishing the role of carboplatin in younger patients of triple negative breast cancer. In similar trial brightness, which evaluated addition of veliparib and carboplatin when compared with addition of carboplatin alone or with paclitaxel, showed that there was a significant PCR benefit with carboplatin, but there was no benefit of adding veliparib. The PCR rate was 58% for addition of carboplatin.
For the DNB by the DNB to the DNB.
Please mute yourself, Dr. Manisha. Please mute yourself.
Similar benefit in EFS was also seen with addition of carboplatin, but there was no additional benefit of adding veliparib. Now, is there any role of immune checkpoint inhibitors? Yes, definitely. With the landmark Keynote 522 trial, pembrolizumab was added to standard chemotherapy backbone in newly diagnosed triple negative early breast cancers in neoadjuvant as well as adjuvant setting compared with the placebo. The trial showed significant benefit in terms of event-free survival. The 36 months event-free survival was 84.5% for pembrolizumab arm versus 76.4% for placebo arm. There was also significant benefit in the pathological complete response rate of 63% versus 55.6%. Similarly, another trial, IM-PASSION 031, compared addition of atezolizumab and another PD-L1 inhibitor to standard neoadjuvant chemotherapy backbone, which also showed the significant benefit of addition of atezolizumab in terms of pathological complete response rate. So, as we have already known, attainment of pathological complete response is associated with significant improvement in survival outcomes and is the surrogate marker for improved survival in case of TNBC and HER2 positive subgroups. This has been proven in multiple analyses. So what if the pathological complete response is not achieved? In that case, the CREATEX trial have compared addition of capecitabine versus placebo in adjuvant setup. This trial showed significant 5-year DFS and OS benefit with addition of capecitabine, proving the role of capecitabine in an adjuvant setup where the complete pathological response has not been achieved. The subgroup analysis in triple negative breast cancer showed similar benefit, which is even more pronounced. The Olympia trial compared germline BRCA mutated HER2 negative high risk primary breast cancers to receive 1 year of olaparib versus placebo in mainly in the high risk subgroups. That is, there was no attainment of pathological complete response or there were multiple lymph nodes positive. So this trial showed the significant 4-year overall as well as disease-free survival in the olaparib arm when compared with the placebo arm. The benefit was also seen in the triple negative subgroup. So to conclude, chemotherapy with dose-dense AC followed by weekly paclitaxel is the preferable chemotherapy backbone. Addition of platinum in younger patients in NCT regimen improves outcomes and should be the new standard of care in younger patients. Addition of pembrolizumab in NCT regimen followed by adjuvant pembrolizumab increases the EFS and has increased the pathological complete response to historical more than 60%. Pathological complete response significantly associated with survival in TNBC and is the surrogate marker. Capecitabine in adjuvant setting in patients not receiving PCR to NCT should be the standard of care, and adjuvant olaparib in high-risk BRCA mutated patient improves outcomes. Thank you.
Thank you, Dr. Narayan. You have firmly impressed again after what Dr. Harpreet had presented. I think, everyone, including surgeons, need to know this, because only then will you be able to ask the right questions of your medical oncologist. So there are very interesting questions whether PCR is actually a surrogate. Has it proven to be translating into better OS? So Dr. Jyoti, if you could answer that question.
Yes, so questions from the chat box. That's what you want me to take?
Yes, so there is a question which says PCR, we use it as a surrogate, but how robust is it as a surrogate? And does it actually translate into OS?
Yeah, so I think Dr. Narayan did show for TNBC in particular, and otherwise for other subtypes also, we know that PCR does, it's a very good surrogate marker. And these studies do favor of its, stronger correlation, especially in subtypes like triple negative and HER2 positive breast cancer. So it is a good surrogate, I would say. And I can also see a question, why does dose dense regime have better DFS? Yeah, so dose dense regime, if you see how the tumors grow, if you know the Norton-Simon hypothesis, that's what we call. So the smaller tumors and the tumors which grow rapidly, they get killed in a better way and faster manner with the chemotherapy. So one way to improve the efficiency of this tumor cell kill would be to increase the dose, but there's a limitation that you would lead to more toxicity. The other impressive way is to decrease the interval between the chemotherapy doses. So thereby attaining a higher dose density. So this dose dense regime works in two fashions, by attaining higher tumor cell kill, and it also prevents the emergence of drug resistance by reducing the interval between the chemo cycles. You get away without getting the emergence of resistant clones. So both these factors, I think, would contribute to result in better disease-free survival.
Right. Adjuvant capecitabine for how long?
8 cycles is the standard. 3 weekly capecitabine, 2 weeks on, 1 week off for 8 cycles. That's the usual practice for adjuvant capecitabine as per CREATEX.
Thank you, Dr. Jyoti, and thank you to the medical oncology speakers and Dr. Rajat Saha as well. Now let's quickly move on to, I know we are past 9 o'clock, so we have to quickly run through the next presentation, which is Dr. Amita, if you're ready. Can you stop share, Dr. Narayan?
Yes, ma'am, I have stopped sharing, but
not going away. Yeah, thank you. So Dr. Amita, if you're there, can you please share screen and quickly run through your presentation? Because
yes,
now,
ma'am.
Yeah. So do it fast.
Is it visible now?
No, you can't see it yet.
Okay.
We're still not able to see it. That's the last slide, I believe.
Is it visible now?
No, not yet. So Amita, if you can't share screen, can you just, quickly run us through what you want? Okay, now we can see. Yeah, we can see it now. Yeah. Yes, go ahead and try and finish in the next 10 minutes, please.
Yes, ma'am.
We have a very interesting panel discussion which is waiting, and I think, and I'm glad to see that we have almost 65 participants still. So please go ahead.
Yes, ma'am. Thank you for the opportunity, ma'am. So I'll be talking about early TNBC cancers. So any ER negative, PR negative, HER2 negative cancer, which is limited to the breast tissue and axillary lymph node.
Come to the radiation bit quickly because this has been discussed several times. Yeah.
So since the data is emerging, has shown aggressive nature of TNBC with high local regional recurrence and distant metastasis, proposing a breast conservating treatment raises concerns. So before offering a breast conservative treatment, we must find out if it has any association with the hormonal receptor status, and is it a viable option for TNBC? If so, can radiation be altogether omitted in TNBC after BCS, since we are now going towards less is more treatment? And if we cannot completely omit radiation, then can we at least omit the regional nodal irradiation? And what is the role of radiation after NSCT in TNBC? So coming to the first question, is there any association between the outcome of BCT and receptor status? So multiple studies have been done in early breast cancer to study the outcome of BCT in terms of local regional recurrence and overall survival in TNBC versus non-TNBC. So majority of the studies showed that local regional recurrence was higher in TNBC, but luckily it did not translate into an overall survival. So the overall survival is independent of the receptor status, though local regional recurrence may be high. Now, which now brings me to my second question: is BCT a viable option for surgery for TNBC, or we should go for a more aggressive surgery? So to answer this question, a study was undertaken by Abdul Karim et al., in which they studied more than 750 patients of early TNBC, and they divided into 3 arms, that is breast conservation surgery followed by adjuvant RT, MRM, and MRM followed by RT. So as we can see in this slide, the 5-year local regional recurrence-free survival and OS was better in BCT arm when compared to the other 2 arms, as it can also be seen in this Kaplan-Meier survival curve, where the survival is on the y-axis and the time in years is on the x-axis. So there's the solid line represents the BCT. So this BCT arm is faring better than the other 2 arms. Also, in another study done by Atkins et al. On the similar lines, he showed that the survival in BCT is better when compared to mastectomy in stage 1. In stage 2 and 3, though it was not better, but it was also not inferior to the mastectomy. And in terms of distant metastasis-free survival, BCT did better than mastectomy in all the stages. And overall survival was also better in the BCT when compared to mastectomy. So to sum it up, meta-analysis was done by O'Rourke et al., who concluded that the administration of adjuvant radiation confers a local regional free survival benefit in TNBC, irrespective of the type of initial surgery is performed. So breast conservation surgery with adjuvant radiation is a perfectly acceptable option for TNBC because of the fact that both local regional recurrence free and overall survival is better than MRM or MRM followed by adjuvant RT. Now, can radiation be altogether omitted in selected TNBC patients? So as far as hormone positive elderly patients are concerned, multiple randomized control trial have been done, which has showed that omission of radiation does not compromise overall survival, even if the local recurrence is slightly higher. But there is no such randomized control trial in TNBC patients. However, there is SEER data, which was published in 2016, where the TNBC, more than 3,000 patients of TNBC who underwent BCS, they were divided into 2 arms. One is for observation and another was adjuvant RT. So the patients who received adjuvant RT, they had a lesser breast cancer specific death as well as subsequent mastectomy, which is a proxy marker for recurrence, local recurrence. So it was lesser in the adjuvant RT arm and it was significant. And in another national cancer database study, after a follow-up of 38 months, 5-year overall survival was higher in the group of patients who had received adjuvant radiation in the order of 77%, compared to the 55% in the surgery alone group. And the benefit was seen across all the ages, even in patients who were more than 80 years. There's a huge gap between the patients who underwent radiation, which is here shown by the solid line, and the darker line, and the patient who were on observation is shown by the lighter line. So there is a huge gap between the two lines. That means that the benefit of radiation is seen in patients who are even elder than 80 years. And the benefit was seen irrespective of stage, as well as irrespective of chemotherapy given. So can we at least, if not totally omit the radiation, can we at least try and spare the nodal irradiation? So MA20 trial was done in stage 1 to 3 breast cancer patients, and as seen in the graph B and D, the patient who underwent regional nodal irradiation followed after whole breast irradiation, they had a better survival than the patient who just underwent whole breast irradiation. So it means that there is a significant reduction of breast cancer mortality, and any breast cancer recurrence by internal mammary or medial supraclavicular irradiation stage 1 to 3 breast cancer. However, it is not converted to improved overall survival. As we can see, the two curves are hugging each other here in the graph A. But in ER negative patients, there was a higher overall survival by the addition of regional nodal irradiation, which was also statistically significant with a p-value of 0.05. So hence, we can come to a conclusion that nodal irradiation in TNBC patients can give a better overall survival in TNBC patients. The role of radiation in the neoadjuvant after neoadjuvant systemic therapy. So earlier, NACT was only given in locally advanced disease to downstage the tumor size and to achieve optimal breast conservation. But now it is expanded to include early TNBC as well, to evaluate response to systemic therapy and optimize the adjuvant treatment. So multiple studies were done which used NACT in a TNBC setting, and as a conclusion of all the studies, it was found that the use of radiotherapy for patients with TNBC in the setting of an NACT is strongly advised after BACS and after mastectomy for patient who has residual positive node. And even if there is a negative pathological axilla, radiation should be considered strongly if there are other high risk features such as young age, high stage, or high grade. So what is the current radiation practice in TNBC? To decrease loco-regional recurrence and improve overall survival, we need to give radiation in adjuvant setting as well as palliation. So the target is the breast or the chest wall along with the nodal regions, and the breast tissue will include all the entire glandular tissue and the lumpectomy cavity, and it is given via mixed energy photons and electrons, and the dose is to the whole breast is 40 to 42.5 gray in 15 to 16 fractions in a hyperfractionated regimen, and it might increase up to 50.4 gray in 25 to 28 fractions in conventional fractionation, and tumor bed boost of 10 to 16 gray is given in 4 to 8 fractions. So how do we, what is the future ahead? So radiation can be used with the immunotherapy, and this has to be studied further since TNBC is highly immunogenic, and hence manipulation of the immune system can be done. The presence of tumor infiltrating lymphocytes in the tumor has a good prognosis, especially if it is seen in the early stages, and immune checkpoint inhibitors can be used both in early and late stages. So what is the promise of combining radiation with immunotherapy? So radiation by itself induces anti-tumor immunity by 3 ways. First is activation of T cells, then upregulation of death receptors, and modulation of the microenvironment and blood vessels. So how does the radiation activate the T cells? So there are something called the antigen presenting cells, These are dendritic cells. They take antigen, tumor-associated antigen from the apoptic and necrotic tumor cells, and they present them to cytolytic CD4 and CD8 cells, and this is called as a cross representation. In the presence of danger signals, that is pro-inflammatory cytokines, these DC matures and activates tumor-specific T cells. So radiation helps in producing these pro-inflammatory cytokines both in vivo and vitro, and thereby they promote maturation of the T cells as well as more tumor killing. Also, radiation upregulates the death receptors such as FAS, CD95, and MHC1, and they are present as a post-stimulatory molecule on the certain tumor cells, and they enhance the tendency of the tumor cells to either die or to be recognized. Also, radiation affects the vasculature of the tumor tissue, and it has a differential response in the normal blood vessels and the fragile blood vessels of the tumor. So since the blood vessels of the tumor are already fragile and which is further increased by radiation, there is increased localization of P-select in the tumor blood vessels, which causes enhanced entry of the affected T cells. This entry is further facilitated by radiation-induced inflammatory changes and changes in the extracellular protein. So more T cells enter these blood vessels and they are able to fight with the tumor cells. Further molecular subtyping of TNBC has been spoken about by previous speakers. So radiation can be used along with these targeted molecules to give a better outcome. However, this is still under study and much more has to be done in the future to take this forward ahead. Thank you.
Thank you, Amita. That was a wonderful presentation because you combined what we currently practice and you've also given us a peek, a view into what the future holds as far as radiation oncology is concerned. Thank you very much. And Dr. Kanika, for your comments, please. Is Dr. Kanika there? Can you stop share, Amita?
Yes, ma'am, I'm trying. Okay, done.
Thank you. Thank you. So I am not able to see Dr. Kanika. But anyways, we coming to Dr. Kanika, are you there?
I think ma'am is in a meeting.
Okay, no problem.
I think ma'am is in a meeting.
So no issues. So what we'll do is we will now bring up the rare, which is actually the most interesting bit. But unfortunately, we have stretched so much. So, but I would request all of you to stay on because this is going to be very, very interesting. And I would call upon my colleague and colleague from Max Hospital, Saket, Dr. Aditi Chaturvedi, who's a consultant breast surgeon, to moderate this panel discussion. And the panelists for this session are Dr. Preeti Grewal, who's a fellow in the breast unit at Max Patparganj, Dr. Naveen, who's a resident in surgical oncology at R&R Hospital, Dr. Grishma, who's a DNB resident at Max Hospital, Patparganj in medical oncology, Dr. Akanksha, medical oncology resident from Dharamshila Hospital, Dr. Monashweta is a radiation oncology DNB resident at Max Vaishali, and Dr. Sushant is a radiation oncology resident at All India Institute of Medical Sciences. So over to you, Aditi. So the next 30 minutes are yours and you can make it as interesting as you please. Thank you. Thank you. And thank you for waiting.
Thank you. Thank you, Dr. Geeta. So I hope all the panelists have joined. I'll just try to share my screen. Can you see my screen?
Yes.
Okay, great. So without further ado, I think we've had some wonderful speakers and they've covered all aspects about management of early triple negative breast cancer, right from surgery to radiation and medical oncology management. This panel discussion, we'll just try to summarize and make sure that our colleagues here, the residents, the trainees, have grasped the key concepts and hear it from them. And I'll try to keep it as short and precise as possible. So we'll use a case to help us in this discussion. So this is a patient, a 42-year-old nulliparous lady who had no family history of cancer. She was premenopausal, regular menstrual cycles. She had history of IVF cycles too. She had undergone IVF cycles twice, but she had not conceived. And she presented to us with a lump in her left breast with a short history of around 10 days. So I think, Dr. Preeti, can you tell me that is this history sufficient? I'll try to keep it as basic as for the help of our residents here. So do you think this history is sufficient? What kind of family history would you elicit? Any young women in any patient of breast cancer, suspected breast cancer? Dr. Preeti?
In a patient who's coming with a complaint of lump in the breast, like I would like to elicit family history of breast cancer, any history of usage of OCP pills or IVF, and if like any genetic mutations are present in the family tree or something like that.
Genetic mutations. So maybe Dr. Naveen, would you like to pitch in? As in, what do you mean by genetic mutations? What kind of family history do you elicit? How do you talk to your patients in your clinic? What kind of questions?
We usually ask the patient regarding any history of any breast, colon, pancreatic, prostate, male breast cancer, any significant history in the first ovarian in the first and the second degree relatives, and this is the main history as far as family history is concerned.
And Dr. Grishma, what about, so Dr. Preeti had also mentioned, and this patient had 2 cycles of IVF. How does that, is that relevant, history of IVF, or in fact, even oral contraceptive pills usage? Is it relevant to us?
Ma'am, the prior use of oral contraceptive pills is not a risk factor, but the current use of oral contraceptive pills is a risk factor for breast cancer. And if there is a prior history of IVF, so IVF involves the use of estrogen stimulants for ovarian stimulation. So that is a risk factor for breast cancer.
Okay. So I think with OC pills, it has been shown that the data is conflicting, but overall, prolonged usage of oral contraceptive pills has been shown to slightly increase the risk of breast cancer. But because they are overall beneficial, there have been no stringent guidelines. But yes, prolonged use it has been shown to slightly increase the risk of breast cancer, although it's protective against ovarian cancer. As far as IVF, I think there was this meta-analysis which was published just last year in BJS, which showed that there seems to be no relation with IVF and breast cancer risk, although I think we do see a lot of patients, but probably that is related to nulliparity and overall cumulative estrogen exposure in these patients. But I didn't find any literature which is showing an increased risk of breast cancer with IVF intake. Dr. Geeta, do you agree?
Yes, you're right. Because, we do see these patients and we keep wondering whether it is, but there is no evidence to show that, in use of, the IVF is known to be a risk factor. Oral contraceptives, yes, more than 10 years of intake is known to show a slight increase, not as much as you would see with the hormone replacement therapy, but oral contraceptives are kind on the fringe. But IVF, very, very dogmatically, our fertility specialists would also say that it does not have any bearing on the risk of breast cancer. But every year, I'm sure all of us see 3 or 4 patients who've had IVF treatment have landed up with breast cancer.
Right. So this lady on examination, she had a 34D breast size, grade 1 toe, and she had a 3 by 3 centimeter lump in the upper outer quadrant near the axillary tail, the extreme upper outer quadrant. The skin, the NAC were normal, skin was just closed, no palpable lump
in opposite breast, axilla, and supraclavicular fossa. So due to paucity of time, I would just directly ask again, probably, just let me see who's the Dr. Akanksha. In such a case, so this is a lady, 42-year-old, who's come with this 3 by 3 centimeter breast lump. What kind of, what would be your next step? What would you ask for?
So I would like to go for diagnostic bilateral mammography. And then I would like to go for tissue diagnosis, including ER, PR, and HER2 status. And at this point of time only, I would like to go for BRCA testing as well.
Would you go for BRCA testing without even confirming your diagnosis?
No, if there is positive, if the cancer is positive, then I would like to go for BRCA testing as well.
Yeah, yeah. So I think since right now we just have a clinical, she's just a 42-year-old lady with a 3 by 3 centimeter breast lump, although there is a short history, but yeah, first would be imaging and tissue diagnosis. And so we went ahead, there was a mammogram which showed, Dr. Preeti, would you like to come in? What can you appreciate in this mammogram per se?
Ma'am, on the left, in the left breast, like a lump can be seen in the left breast in the outer quadrant, and while the axilla shows no lymph nodes as such, and
they're dense breast per se.
Dense breast, yes, ma'am. ACR C.
Okay. And so since she was 42 with a dense breast, we went ahead with a MRI, and which showed a similar finding that there was a 3 by 3 centimeter enhancing lesion in the upper outer quadrant with no axillary lymph nodes. So what kind of a biopsy? I think we can get our radiation oncology colleagues to come in. Dr. Sushant, what kind of a biopsy would you ask if this patient lands up in your clinic? What kind of a patient biopsy would you ask your surgical colleague to do it, or would you send it to your imaging department for a biopsy?
Yes, ma'am. I would send for a USG guided true cut biopsy from the lump, and in the meanwhile, the USG will also check for any nodal lymph nodes in the axilla as well. And if at all they find anything in the axilla, they will take an FNEC from there as well.
So absolutely, I think you're right that we would ask for ultrasound guided core biopsy and at the same time ask for an assessment of the axilla. So that was exactly what was done, and a biopsy showed grade 3 IDC, which was triple negative with a high key 67 of 70%. And ultrasound axilla showed that there were no significant lymph nodes. So, Dr. Mona Shweta, would you ask for any staging, a whole body scan, a PET or a CT bone scan, anything for this patient?
Since it's basically a stage T2 and not M0, so it's not quite necessary to go for staging, but we can definitely go for PET scan to see whether there is another involvement or whether there is any sort of metastasis. Because if we are dealing with triple negative breast cancer, it has high chances of distance metastasis.
Right. So it's an aggressive histology, yes, but yes, there's no textbook recommendation of a staging investigation in this case. But yeah, since she's 42, she's triple negative. You can counsel the patient about the near. Dr. Sushant, the names, would you get a staging investigation done for her?
Ma'am, this is an early cancer, so maybe I'll get a low dose CT scan of chest, abdomen, and pelvis along with bone scan. And since she's she's having this ptosis grade 1, so maybe I'll get one MRI brain also, because she is TNBC. She has more propensity of visceral metastasis as well.
Sorry, I didn't get it. Since she had ptosis, what did you say? If she has ptosis then?
I will get a MRI brain done because
this is ptosis. This is
breast
ptosis. This is not eye ptosis.
Okay.
Yeah.
Ma'am,
yeah.
clinically T1, T2 wouldn't warrant a staging investigation like PET CT. So a chest X-ray and an ultrasound abdomen should be sufficient, ma'am.
Fine. So basically the only takeaway I wanted residents to get during the workup is pay focus on
history, hormonal exposure, then prefer an image-guided core biopsy if you have access to such services, ultrasound evaluation of the axilla. And as far as staging is concerned, although this is a T2N0 clinically, but I would say that we would discuss with the patient, and there are, in fact, I think quite a few of us would tend towards getting some staging investigation for this patient. So anything else? Now, I think Dr. Grishma or Dr. Akanksha, one of you had mentioned about genetic testing. So what would you ask? What would you do? How would you suggest this patient to get a genetic test done? Or what would you recommend?
So basically, multi-gene panel assessment should be done, which
Right.
includes not only BRCA, but also other genes like PTEN or ATM, PALB2, which we have already seen. So these can also be picked up. Although there is low rate, maximum is BRCA, but these can also be picked up. So multi-gene panel assessment to be done.
Right, but would you directly advise the test, or since what we heard from our speaker, Dr.
No,
Charu?
pre-genetic counseling is very necessary. Before that,
Right.
the pre-genetic counseling is very necessary.
Hmm.
And apart from this, I would also like to go for 2D echo. Since if we plan for neoadjuvant chemo, then and anthracycline-based chemo, then it will be necessary.
Right, right. So you would get a basic blood labs and a 2D echo,
yes,
because she might need neoadjuvant chemotherapy. So again, to reiterate, she does fulfill the criteria that she needs genetic testing. It should be recommended, but only after apt pre-test counseling, because there are implications of getting these tests done. And I think all of you, we need to remember that adequate counseling and what would be the options, or what would be the scenario after we get the test results should be discussed with the patient beforehand. And regarding fertility, so she's 42, she's nulliparous, she's had 2 unsuccessful IVFs. What would be your take on that? Maybe Dr. Preeti?
Ma'am, I would like to advise the patient regarding that fertility part, because she already had a history of IVF and she's nulliparous. So whether at all she's interested in fertility options, like as she has already been diagnosed with breast cancer. So if she's still interested in conceiving, so probably fertility counseling would be the advised mode of treatment for her before the actual treatment starts for breast cancer.
Right. So I think even if she is 42 and you would think that maybe, and since she has history of 2 failed IVFs,
yes,
but I think referral to an oncofertility specialist to see what are the options must be done before we commence her oncological treatment.
Yes.
So regarding management, I think this is a question I would like to ask all 6 of you. What would be your take? Neoadjuvant chemo versus upfront surgery. She has a 3 by 3 centimeter tumor, no axial lymph nodes, breast size is 34D, breast conservation, she's upfront operable. Breast conservation seems possible, although obviously it's a 3 by 3 centimeter tumor. So with margins, you would require some form of oncoplasty. It's a lateral tumor, so a perforator-based flap would suffice. But would you go for NACT versus upfront surgery? So Dr. Naveen, maybe just a word.
Ma'am, in this, because it's a grade 3 and it's a Ka67 is also high, we would basically go ahead with the NACT with the clip placement, and then the initial plan is that of a BCS in terms of a good tumor to breast ratio that is also facilitated, and then we check the further response assessment with the histopathology report on how to proceed further.
Right. And Dr. Grishma? Anyone who differs, anyone who would not want NACT.
Yes, ma'am.
Do all the 6 panelists agree that it would be NACT? Is there anyone for upfront surgery?
Yes, ma'am, NACT.
NACT. Okay. So what are the possible cons of NACT? What would you counsel the patient when you are counseling them for NACT? Fine, I agree. In fact, she was given neoadjuvant chemotherapy. But I would like to understand from you, probably Dr. Akanksha, that when you're counseling her about the role of neoadjuvant chemo in her case, what would you tell her? What are the possible pros and what are the cons?
So basically, I would counsel the patient that because it's an aggressive tumor, so definitely NACT would help us a lot in knowing the PCR rate actually, because it can transfer into overall survival. So that is one thing. Another thing is that if we don't have any PCR, then we can always tailor the approach. Means we can add some adjuvant treatment. So that is the second pro. So that is the second positive point I would tell the patient for that.
Right. And is there a survival benefit of adding NACT, Doctor?
No, as of now, no overall survival benefit. But then there is increase in the PCR rate. So that would translate into overall survival benefit as per various studies. Not exactly, we don't have any overall survival benefit as of now.
Right.
Ma'am, sometimes we do need to counsel the patient that the disease might progress when the patient is put on NACT. So there are like chances if the disease progression takes place during the NACT period.
Right. So I think what I think Dr. Grishma or Dr. Akanksha said that the main two advantages of giving neoadjuvant chemotherapy are that you get to know what would be the in vivo response in terms of whether the patient is the tumor is attaining PAT-CR or not, and that is a surrogate marker for overall survival, even though there is no survival benefit of neoadjuvant chemo. And the second thing is residual disease. You get to see if there's residual disease, and accordingly you can tailor offer other therapeutic agents if the patient has not achieved PAT-CR. But does every triple negative breast cancer patient need chemo? Dr. Mona Shweta, what is your take? Does every patient who has triple negative breast cancer need chemo?
Ma'am, on the basis of staging, we can go for means like any, since it's a highly aggressive disease, so it's been shown that chemo does have a very good effect. So to improve this survival, so we should go for chemo. But
is there any subgroup where you can avoid chemo, forget neoadjuvant or adjuvant, where you can avoid systemic therapy? Maybe someone else, Dr. Naveen, if you can come in.
Ma'am, in T stages less than T1C, in very small tumors, it has been found that directly one can go ahead with surgery. With the N0 disease, if there is N plus and there is already a nodal met, then generally new adjuvant approach is considered better. So generally for a T1C less than 1 cm primary lesion, an upfront surgery can be.
Not T1C, T1A.
Base, yeah.
Ma'am,
Yeah.
So I would like to answer, ma'am, basically more than 0.5 centimeter and node positive. These are two subsets, then we always have to give chemo. Even in less than 0.5 centimeter, even if it is 4 to 5 mm, I'll discuss this thing with the patient that there is mild benefit, but then there is benefit. So yes, more than 0.5 and node positive definitely, but less than that also I will discuss.
Right. So T1A N0 less than 5 mm is a subgroup where the role of chemo is not established. T1B onwards, chemo is required, but neoadjuvant chemo is generally, as per current guidelines, recommended if it's T2 and above. That means more than 2 centimeter or node positive. But I think the only subgroup where you can avoid chemotherapy is T1A N0, right? So,
and I'd like to just add, this is just a fun element. You don't have to really delve too deep into it. But if you have an adenoid cystic carcinoma in a breast, it may be a triple negative. It is usually a triple negative. There you can get away without chemotherapy. Strangely, adenoid cystic carcinomas in breast behave very well as compared to triple negative, adenoid cystics in the head and neck area.
Right.
So that's just a snippet, nothing of...
Yeah, no. Great. So I think adenoid cystic is another variant then, and T1A N0, where you can consider avoiding chemotherapy. So this we've already discussed what are the benefits of systemic therapy. I think both our medical oncology speaker and surgical oncology speaker have gone into that, so I will not go into the details. So since everyone agreed that they would like to start with neoadjuvant chemotherapy, so let us ask Dr. Grishma, what would be your choice of regimen? What medicines, what drugs would you offer this patient? Which regimen?
Ma'am, I would give 4 cycles of, I would start with 4 cycles of anthracycline plus cyclophosphamide, dose dense, followed by 12 settings of weekly paclitaxel plus platinum. I would like to add carboplatin, and also pembrolizumab.
Would you give pembrolizumab in this patient? She's T2 and 0.
Ma'am, given the data from the keynote 522, the pembrolizumab has a higher PC, addition of pembrolizumab has higher PCR rates. So I would like to add immunotherapy.
Is it even in this setting? Is it even in the, you would basically, you mean to say that you would consider this as high risk TNBC? What about Dr. Akanksha? Would you
Yes,
also agree?
Yes, ma'am. I would like to go with the same regimen because in keynote 522, there is T2 subset also which has been included, and overall PCR rate is better. Even if we see the forest plot, then also in T2 subset also there is benefit. So what regimen I would offer to the patient will be anthracycline, that is doxorubicin at a dose of 60 milligram per meter square, along with cyclophosphamide 600 milligram per meter square 3 weekly, along with pembrolizumab 200 milligram, followed by taxane carboplatin plus pembrolizumab, and I would continue this pembrolizumab after surgery for a total of 9 weeks.
9 cycles.
So do we have a medical oncology consultant here? I'm trying to see if we have someone. Dr. Rajat or Dr. Jyoti, would they agree? Would they offer Pembro to even a T2 node negative patient? But I don't think we have any medonc consultant here. Dr. Geeta, what would your call be?
My understanding, you have to take it with a pinch of salt. This subset analysis makes me very wary. The more you break it down, the results will look very, very good. So, for me, as of even in keynote, they do show that the margin of benefit is higher for those with high risk features, effectively node positive. So it is node positive patients that you would see a higher degree of benefit rather than those with just T2 tumors. So, you have to look at that because, it is not an easy treatment. It is expensive. We have to factor all of that in also. And like I said, pathological complete response is a surrogate marker, I agree. But, the robustness of PCR translating into overall survival benefit is what we're looking at, and we're still not quite there. And it's been 25 years since neoadjuvant chemotherapy has been in place, and we're still struggling to answer that same question again and again. So I have my reservations about it, but of course, my medical oncology.
Right. I think I agree with you because I would also, we would give AC followed by taxane and platinum agents. Yes, I think with the new Tata trial, and since she's young, she's just 42. But immunotherapy, I think Dr. Lima, are you there? What I saw. Anyway, so, and before neoadjuvant chemo, when would you clip the tumor?
Oh, clipping would be done, ma'am, post 2 cycles of chemotherapy.
You do it after after 2 cycles. Would anyone clip upfront? Would anyone clip at the start?
Can be done, ma'am, before the start of the NECT.
It can be done, ma'am.
Before the start of the NECT.
So generally for a smaller tumor, 2-3 centimeter tumor, triple negative and HER2 positive especially, I offer clipping right at the onset. In a larger tumor or hormone positive, that is when I delay clipping. That is what we practice here. But I think you can argue it either way. And so clipping and port placement was done, and she received AC followed by paclitaxel carboplatin, how would you do the response assessment? Actually, another thing, would you complete all chemotherapy, or is there anyone here who would offer a sandwich kind of, like give some chemo, then operate, and then finish the chemo? Among the 6 of the panelists.
Complete all the chemotherapy first.
Yes, ma'am. Complete all the chemotherapy first.
Ma'am, response assessment is required after 2 cycles.
Right.
So only after that assessment we can decide whether we go ahead with the same, or we need to intervene with the surgery, because it's an aggressive disease. So there is high chances that the disease might actually progress if it's a stable disease even after 2 cycles chemo, which is for TNBC is unlikely, but still 2 cycles reassessment, then go ahead with further chemo, or then if not, then surgery.
Right. So I think after 2 cycles, we generally do a clinical examination and sometimes supplemented with an ultrasound. And then after completion of AC or paclitaxel, whatever you started with, and complete all chemotherapy if the patient is responding well. The only time we interrupt it is if the patient is not responding well, or if the patient is not tolerating chemotherapy as well, if there are side effects limiting the dosage and delivery of chemotherapy. So this patient had, we got the genetic results also. She had one VUS and BRCA2, good clinical response, no residual lump, and response assessment imaging again showed that there was just a irregular hypoechoic lesion query, just a fibrotic patch, nothing significant, and the axilla was cleared. So again, wire-guided breast conservation surgery and sentinel node biopsy was done. So Dr. Maybe Preeti, would you be comfortable offering a sentinel lymph node biopsy in this patient?
Yes, ma'am. For her, we can offer sentinel lymph node biopsy because to start with, she was a clinically N0. And so sentinel lymph node biopsy would be the preferred way of addressing the axilla. So yes, ma'am.
So, and in case she was N1, suppose her FNA axilla was positive upfront, would you still consider offering sentinel lymph node biopsy post chemo?
Yes, ma'am. Again, I would go ahead with SLNB even if she was N1 to start with. And like in SLNB, if the node came out to be positive, then definitely would proceed to axillary dissection. But if it would be negative, the sentinel lymph node, then we would stop at the SLNB only.
But in N1, ma'am, then we have to put a marker in that node also.
Yes, ma'am. That is like for the case was if the case was different. She's N0, so that is why clip placement was not done. So if she was N1 to start with, the clip placement would be done for the node as well.
Would you not be comfortable offering post chemo sentinel lymph node if clipping of the axilla wasn't done at presentation?
Ma'am, even then SLNB would have been the way to start. Axillary dissection only if the nodes came out to be positive. So even if the clip was not placed in the axilla, even then SLNB would be the preferred way of dealing with the axilla.
After NACT, ma'am, also then SLNB can be attempted, but minimum of 3 lymph nodes, 3 or more needs to be removed. Then it has been found out that the false negative rates, if these many number of lymph nodes are removed, then it is comparatively less than 10%.
You have to be very careful when you make these statements. See, in an N1, I would definitely want a clip. I want to reduce my FNR. If I'm not clipping the node and I'm doing a sentinel node without any targeted node there, I would, the FNR in the Sentina and the ACOSOG 1071, the Alliance trial, all were in excess of 12%, 14%, not acceptable. So, the targeted axillary dissection along with sentinel node biopsy, where you pick up at least 4 nodes, then your FNR comes down to 2%. So that would be a preferred method of doing in a clinically node positive. In this situation, I agree. You can go ahead and do a sentinel node biopsy because initially the axilla was negative.
N0.
This is absolutely fine. But in an N1, one has to find some method of targeting that node and ensure that you get that node out.
Or a radioactive, yes, ma'am.
Yes.
Right. So I think in this patient where that it was clinically and radiologically N0 upfront, you're comfortable with a sentinel. In a upfront N1 patient who's turned N0 after neoadjuvant chemo, you have to be careful offering sentinel lymph node biopsy. Dual dye, 3 nodes, and preferably clipping of the nodes. Although there is a lot of data emerging where if the node has not been clipped and it was N1, that means 1 to 2 node positive upfront, you can consider, as long as the other criteria, at least 3 nodes is the main criteria to ensure that your FNR is falling well below 10%. Anyway, so this patient underwent this surgery. Her final histopath showed pathologically complete response. Regarding further treatment, so our medical oncology colleagues, Dr. Grishma, she had a PCR, what would you discuss with the patient if she has received Pembro upfront and if she has not, in both the situations, please?
Ma'am, if she has received pembrolizumab, then I would continue pembrolizumab up to 9 cycles, because irrespective of PCR, we have to, as per the keynote trial, we have to give pembrolizumab. If immunotherapy was not given in neoadjuvant setting, then there is no role of adding it in adjuvant setting. And since the patient has achieved PCR and there is no residual disease, so there is no benefit of adding any other adjuvant chemotherapy also, such as capecitabine or anything.
Yeah. So Dr. Akanksha, when would you consider adding capecitabine and olaparib as a maintenance treatment in triple negative breast cancer?
So basically, if there is no PAT-CR, means there is residual disease left, so I would offer after NACT. So I would offer patient capecitabine for a total of 8 cycles at a dose of 1250 milligram per meter square, 3 weekly. And if there is no residual disease, then I will not give capecitabine. But olaparib I would offer when there is BRCA positive patient. So for that patient, I would offer olaparib for a total of 1 year.
Both BRCA1, BRCA2 mutated patients?
Yes.
Okay. Okay. And Dr. Sushant, what about radiation? She's undergone breast conservation and sentinel lymph node biopsy. What kind of radiation would you offer this patient?
Ma'am, since she has got just breast conservative surgery, we have to give radiation to whole breast, and since and SCF also, ma'am, supraclavicular fossa.
Okay. With the tumor boost?
Yes, ma'am, with the tumor boost as well.
Even if she has achieved PCR, you would go ahead with your tumor boost?
Yes, ma'am, I will go with the tumor boost.
And Dr. Mona Shweta, what are your thoughts? What about regional nodal irradiation for her? Any discussion about that?
If on regional nodal radiation, we only do the common indications are that if it is a high risk case with no axillary dissection, or if there is a axilla, like if this is SLNB is positive with no dissection. So in those cases, we do go for regional nodal irradiation. So it certainly depends on SLNB result, like if it is positive or not. So then we have to decide whether we have to go for regional nodal irradiations or not.
So this patient was N0 at presentation, so probably we can skip that. But if she was N1 converted to N0, and would you still consider irradiating her regional nodes?
Yes, ma'am.
You would?
Ma'am, in this only if actually the lymph node dissection is inadequate, ma'am. If this is less than
Actually,
10,
there is difference in opinion regarding this. The ASTRO guideline says if there is residual node positive, means of YP N1 N plus, then only we have to give. But the European guidelines say we have to give RT depending upon the initial clinical presentation which we had. So this can be individualized and a radiation oncology can take a call, but generally we follow ASTRO guidelines. So maybe nodal irradiation will be done only if there is residual node positive disease.
Right. I think that's a dilemma which most radiation oncologists face, that if the patient was upfront node positive and has become node negative, would you consider regional nodal irradiation or not? And I think people, because of this confusion in guidelines, they tend to irradiate the earlier nodal basins as of today, but that there is scope for de-escalation in the future. And even in post-mastectomy radiation, so we know that the indications of post-mastectomy radiation are T3 and above or node positive disease. But
Yes,
is triple negative a high-risk feature to irradiate patients even in T2N0 setting?
ma'am, there is this early Danish trial which showed that post-mastectomy RT reduces the loco-regional recurrences in TNBC, but there is no um, benefit seen in overall survival. And also, ma'am, in the previous discussion, quoted a study by Abdul Karim. There also, he told there is benefit in overall survival after post-mastectomy RT in T3 and above disease. So, a T2N0 disease going for mastectomy, we can omit this.
Yeah. Although it's a high-risk feature, but at present, I don't think it's a classic indication for a post-mastectomy radiation therapy alone on the basis of triple negative disease. So I think our medical oncology colleagues have anyway covered that if you've given neoadjuvant chemo plus minus pembrolizumab and then operated, if there is PCR, then as of today, there is, because of that keynote 5-2, you consider continuing adjuvant pembro. Although there are trials about the role of adjuvant pembro in such a scenario. And if there's no PCR, then on the basis of BRCA1 or 2 mutation, you decide whether the patient needs olaparib or capecitabine. I think that's a dilemma which medical oncologists do face because there's no head-to-head comparison of giving either of these medicines. Though Createx trial did not have an olaparib arm and vice versa. So what else? Can one of you, maybe Dr. Preeti, can you tell me what would be the follow-up strategy in this patient? What are the recurrence patterns in triple negative and how is it different from hormone positive breast cancer?
Ma'am, TNBC is usually 40%. They tend to recur like within the first 3 years. And if they survive like without any recurrence during the first 5 years, then they usually have a better outcome or a 10-year survival rate. So, and the follow-up strategy would be, ma'am, like the regular follow-up protocols that we have every 3 months for the first 2 years and every 6 months for the next 3 years. That would be my way of following up the patients. And if she has undergone a breast conservation surgery, then definitely alternate mammogram with MRI every 6 months would be a way of keeping up with any recurrence, loco-regional recurrence in the breast.
Would you do a MRI routinely in follow-up after breast conservation?
Mammogram every 6 months, alternating with MRI in the next 6 months. That would like.
Are you talking about BRCA mutated patients or patients after breast conservation?
In our case, ma'am, it was a VOS BRCA2. So
yes,
mammo with a MRI is.
What does VOS mean? What do you understand by the term VOS?
Ma'am, it's a variant of unknown significance. So basically, the actual its penetrance of that particular mutation of actually resulting in is not known. But still, if such a presence is there and we are not doing any kind of risk reduction surgeries for the patient, it is always better to follow up the patient at a shorter intervals.
But okay, in case a patient has a VOS, you would not offer a risk reduction surgery on the basis of VOS.
We will not offer. We will not
Yeah.
offer, ma'am.
I mean, VOS we will not offer.
Right. So you would not offer any risk reduction surgery.
Yes, but regular follow-up would be mandatory.
It's still a high risk, but still the patient is a higher risk.
Under surveillance, the patient has to be kept so that any recurrence pattern can be noted earlier, the better, ma'am. It's like that.
So if you would have told me that you would want to keep her under like anything more than an annual mammogram because of a younger age, I would still probably encourage that discussion or maybe say that, yes, it's open to discussion between you and the patient. But I would not say that on the basis of VOS alone, you should offer her an alternate mammo MRI strategy. Dr. Geeta, your thoughts?
So in a mutant, yes, alternate 6 months mammogram and 6 months you would do MRI. But on a regular triple negative, you don't have to get paranoid. Actually, I get very upset when I see a lot of PETs being done in follow-up because, we are chasing the disease and keeping the patient always on tenterhook, which is not a great idea. Because triple negative, whether you do a, 3-monthly follow-up, do all the investigations, if she has to fail at 3 years, within 3 years, she will fail like the clock, So
Yeah.
I think you should not, but of course, I'm sure our medical oncologists want to catch things early and possibly change the outcomes. But we do know once triple negatives fail, it is tough to catch the bottom. But yes, we must try and catch it early, but we should be symptom guided as far as I'm concerned in terms of follow-up. Nothing different for me, even if it is a triple negative breast cancer.
Right. I think I agree that symptom driven, clinical examination driven, annual mammogram, and you can do a clinical exam, maybe do an ultrasound of breasts if clinically indicated, but MRI not on the basis of a VUS alone. And PET scans, again, need to be avoided as a routine follow-up strategy. There's no evidence to say that routine PET scans do help until and unless your symptoms or your clinical examination are picking up some worrisome features. I'm skipping the discussion about the future, but I think we know that there are trials. There's a study which has come from MD Anderson, which shows that there may be a future of somewhere omitting local treatment, omitting surgery in patients with PAT-CR, with radiological CR and doing VAP-guided biopsies. And there is a lot of emerging data about de-escalation of chemo also, omitting anthracyclines or de-escalation of radiation. But I think that's a discussion for another day. So that's about it. Thank you. I hope this was useful.
It was great because